friends to join in. All right, guys, I'm joining the session now. Before beginning, I would like to ask you that are there any questions that you would want to ask me in terms of USMLE preparation or anything at all in general? If there are any questions, please ask me right now. Otherwise, I am starting the session. No? Okay. So I'm sharing my screen. Yeah. So the first question for today is that the cardiac murmur is heard on auscultation. Both carotid arteries demonstrate a rapid rise and fall of the arterial pulse. Okay. Partial compression of the femoral arteries by the stethoscope elicits a systolic diastolic bruit. Which of the following sets of pressure findings is most likely to be observed during cardiac catheterization of the patient? So what's happened is that there's this 33-year-old man. He comes to the office due to fatigue and decreased exercise. The patient was diagnosed with infective endocarditis. We know that. We know what that is because he was an IV drug user for a very long time and he completed his course of antibiotic therapy. Okay. So what do you think is happening in this patient? Anybody?
Aortic regurgitation.
Okay. And because of that, what will happen?
Left ventricular pressure increases.
Okay. So what do you think the answer will be? Come on, guys. There are 40 students in this class, and I'm only hearing 1 to 2 people answer every time. Why is that? Don't you guys have to give your step one?
I think the answer will be D, because both left ventricular pressure and aortic pressure will be increased, mostly systolic, and then diastolic will reduce, will be decreased. So it would be the right answer for me.
Very good. Again, we know that the patient's presentation was consistent with aortic regurgitation. That's also a complication of infective endocarditis. And because there's this loss of aortic pressure, and you see that during diastole, there's this backflow of blood into the left ventricle. As a result, the left ventricle, it becomes very, very dilated. And you also have an increase in the end diastolic volume, and the heart undergoes eccentric hypertrophy. What do you mean by eccentric hypertrophy?
Like when the blood is flowing more.
Dilated cardiomyopathy.
Blood is flowing more into the heart, so it is increasing its vasculature. So that's called eccentric hypertrophy.
Okay. Are the sarcomeres been added in series or parallel?
I think there are parallel.
Series.
Series.
Dilated cardiomyopathy.
Series.
Yeah, it's in series.
Very good. In parallel, that happens in concentric hypertrophy. Okay. And there is this also in for aortic regurgitation. What I want you to remember is this educational objective. This is very high yield. Again, they talked about that. The hemodynamic changes, they create a characteristic pressure changes, including reduced aortic diastolic pressure. The other thing you will also see that there is a vast difference between the systolic and diastolic blood pressures. You can see this over here as well. Why is that? Because that's very characteristic of aortic regurgitation. Increased aortic systolic pressure and increased left ventricle diastolic, and systolic pressures. Again, a concept-based question. They did not ask you anything else aside this. All right. Next question. Okay. Physical examination shows normal lung sounds and no lower extremity edema. His medical treatment is modified with the addition of a combination pill that inhibits neprilysin and blocks angiotensin II receptors. What is this drug called?
Sacubitril.
Cubitril. What does it do?
It's a neprilysin inhibitor.
Okay. And what effect will it do on the heart?
Valsartan will be added with it.
So we know that they're talking about sacubitril over here because it inhibits neprilysin and blocks angiotensin II receptors. Which of the following is most likely the effect of this medication? What does it do? If it blocks angiotensin II receptors, then what's going to happen?
It increases the urinary sodium excretion because it's increasing the levels of ANP and BNP.
Very good. Again, so this RAS is what you need to be very familiar about it. What can anybody tell me? What is RAS? Renin angiotensin aldosterone system. Can anybody tell me? Explain me. Guys, what is renin angiotensin aldosterone system? Anybody? No?
It's a system that's in the kidneys. Renin stimulates production of angiotensin II, which stimulates the aldosterone secretion, which aldosterone stimulates the reabsorption of sodium and water in exchange for potassium.
Okay, very good. Anybody else? Guys, this is your
When
chance.
there is low volume of blood or fluid in the body, renin activates in the JG cells. It activates angiotensin, which angiotensin, and angiotensin is converted to angiotensin II by angiotensin converting enzyme from the lungs. Angiotensin II stimulates aldosterone, which retains water and sodium in the body.
Exactly, very good. All right, so this ANP and BNP, where does the ANP come from and where does the BNP come from?
Mitral natriuretic peptide, brain natriuretic peptide.
From brain.
No,
From the
that's
brain.
from the ventricle. That's from the ventricle.
So
When it
ANP
is
comes
under
from the
stress.
atrium, BNP comes from the ventricle, okay? And that is why you see a rise in BNP in what type of failure?
Heart failure.
Heart failure.
Heart failure.
Again, I want you to be familiar with the physiology of renin-angiotensin aldosterone system and what ANP and BNP are derived from. We see increase in BNP in heart failure as well. So this is neprilysin, and this is sacubitril. This is valsartan, and it kind of blocks this. And as a result, what's happening is vasoconstriction and fluid retention. We know what's happening. Blood pressure is going to increase. Aldosterone is going to increase. There's fibrosis and remodeling. And if there is vasodilation and diuresis, and the opposite of that is going to happen. So sacubitril and valsartan are kind of like, going hand in hand together. Sacubitril is, blocking out neprilysin, and valsartan is, kind of blocking down angiotensin II. All right. And because of that, their effects are blunted out. And if you kind of go down and you can kind of see this educational objective, again, very high yield for you to go through. And that is why I put an immediate focus on the educational objective, because this is the only thing that you need to take away from this. The other is just, for explanation purposes. So you know that neprilysin, it is responsible for the breakdown of the natriuretic peptides in angiotensin II. And once there's inhibition of neprilysin, it increases the activity of peptides. Again, for treatment of heart failure, neprilysin inhibition is combined with angiotensin II receptor blockade, so that the effects are increased, and as a result, vasodilation and diuresis occurs, and it blocks the negative effects of angiotensin II. You can see this over here, that again it's going to block the vasoconstriction and fluid retention, and it's going to increase, it's going to be wanting to do more vasodilation and diuresis. Okay. All right. And because diuresis is happening, and that is why there's increased urinary sodium excretion that's occurring. All right, next question. So the temperature is 98.1. Blood pressure is, the patient is really hypotensive. Okay. Pulse is erratic. Respiration is okayish. Extremities are cold and clammy. Diaphoresis is present. ECG shows STEMI in the lateral leads. Which of the following hemodynamic changes are most likely present in the patient? So there is a 65-year-old woman. She comes to the hospital because of sudden onset chest heaviness and SOB that began an hour ago. Her medical history is, diabetes, obesity, and hypertension. What's going on? What's going on?
Myocardial
Pulmonary
infarction.
infarction.
Shock.
Shock.
Hypovolemic shock.
Shock.
Cardiogenic shock.
Shock.
Cardiogenic.
Cold and clammy. Shock.
Shock. Very good. So, you see that there's hypotension going on, cold and clammy. Probably she's in shock. What's going to happen?
Cardiac contractility increases as heart rate is more.
Okay.
Systemic vascular
Systemic
resistance will also
vascular
increase to
resistance
try and
increase.
improve cardiac.
Increase
actually,
because
the
there is
cardiac-
cold extremities.
The cardiac contractility will
No,
decrease.
yes,
It
the
will
cardiac,
decrease.
yes, and then the
Contractility will
systemic. I'll
It's
go
not
for
utility
C.
will decrease, and to restore the blood pressure, the systemic vascular resistance would appear to increase. And at the same time, the pulmonary artery systolic pressure, like towards the back, it will also be increasing because of the
Correct.
change in diastolic volume of the left ventricle.
Correct.
Would we
C.
see?
Yes.
All right. Again, I told you that whenever there is any sort of MI, she's undergoing through myocardial infarction. You see that the ST segment elevation STEMI, that's most probably they're referring to cardiogenic shock. Remember what I told you in cardiogenic shock, that the PCWP is always going to be increased. It's going to be that type of shock where PCWP is going to be increased, and the rest of the types of shock, the PCWP is going to be decreased. All right. Again, if it's a cardiogenic shock, which means the heart is stopped pumping, so of course the cardiac contractility will decrease. And we talked about that how cardiac contractility and SVR go inversely proportional. All right. Most of the times their arrows will be opposite. All right. So if the cardiac contractility decreases, the SVR is going to increase to compensate. And the pulmonary artery systolic pressure, again, it's going to be increased. Why? Because there's a backflow of blood that's going to happen. And if you kind of see this over here as well, see that there is increased pulmonary capillary bed pressure. Like I told you guys, that happens in cardiogenic shock. Very high yield for you to differentiate between types of shock. If you need to differentiate between types of shock and you're unable to find out what's happening, just check the PCWP. If it's increased, most likely they're referring to a cardiogenic shock. And if it is not increased, it's decreasing, then they're referring to any other type of shock, which is except a cardiogenic shock. Okay. And you can kind of go down and this. Okay, what happens in an obstructive shock? Can anybody tell me what's going to happen in an obstructive shock to the cardiac contractility, to the SVR and the pulmonary artery systolic pressure? Anybody?
What do you mean by obstructive shock?
Obstructive shock is cardiac tamponade. Now, what's going to happen in cardiac tamponade?
Okay.
Cardiac
Will
Okay.
decrease
Yes.
resistance.
There will be increased JVP.
Okay.
JVP. There's what else? Yeah. JVP.
With the tachycardia, there's increased JVP. There is reduced feeling in the heart because the heart is tight. It's
Triad.
fluid around the heart. And then there's hypotension. Yeah, the triad.
Okay. Very good. So obstructive shock can either be cardiac tamponade or it can be tension pneumothorax, pulmonary embolism. In this, if I'm talking about just obstructive shock in terms of cardiac tamponade, then the CVP is going to be increased. What's going to happen to PCWP?
Increase.
Increased. Very good. Cardiac output is going to be decreased. The SVR is going to increase. And what's going to happen? Saturation venous oxygen, it's going to be decreased. But if I'm talking about pulmonary embolism or any sort of tension pneumothorax, then what's going to happen? Are the arrows going to remain the same? Yes, except PCWP. All right. So because it's not, heart in origin, so that is why the PCWP is going to decrease and all of the arrows will remain same in, pulmonary embolism or any sort of tension pneumothorax, because that is also a kind of an obstructive shock. Again, I told you guys this again and again, the PCWP is very, very, heart oriented. Okay, it's very heart oriented. So if it's going to be a cardiogenic shock, PCWP is going to be increased. If it's a obstructive shock, depending if it's an obstructive shock of cardiac tamponade, then the PCWP is also going to be increased. Otherwise, PCWP always decreases. Okay, is it clear, guys?
Yes.
Okay.
Ma'am.
Yeah.
Ma'am, is the PCWP increased in cardiogenic shock or decreased in cardiac?
Yes, it's increased in cardiogenic shock.
Okay, ma'am.
Okay. All right. So what's happening? That a sodium nitroprusside infusion has begun. Which of the following left ventricular pressure volume relationships best represent the effects of this therapy? All right. So what's happening with this 45-year-old man? He comes to the ED due to a 2-day history of dyspnea, orthopnea, and ankle swelling. The morning he had nausea, vomiting, and a headache. Blood pressure is elevated, and physical examination shows pulmonary crackles and bilateral pitting edema up to the knee. So a sodium nitroprusside infusion is begun. And what does sodium nitroprusside do? Solid line is before nitroprusside, dashed line during nitroprusside infusion. Okay, what will nitroprusside do on the heart?
Vasodilation.
Cause vasodilation.
Venodilation.
Okay, what will happen to the stroke volume and diastolic volume? What's going to
It
happen?
increases the
will
preload and
increase.
afterload.
Okay, so is it A, B, C, D, or E?
So actually, this
B, ma'am.
I think the preload would decrease.
Okay.
Because the volume of because vasodilation is occurring, so it is affecting the venous tone. So that's why the preload would decrease.
Okay.
And
E.
the overall end diastolic
we-
would decrease.
Yeah, you're right. So we need to decrease the preload. Why do we need to decrease the preload? So as to, put less pressure on the heart. All right. The heart is already, doing its maximum capacity, and we're already having pulmonary crackles and, pitting edema, and then there's this dyspnea, orthopnea, all of that's going on. So we need to decrease the preload, and for that, we give sodium nitroprusside. So what will be it looking like on the graph?
So it will get shorter than the actual one.
Okay.
That would be like E, because it is getting shorter.
E.
The end diastolic volume is decreasing. It is getting on the or downside.
Again, yes. So the patient was suffering from acute heart failure due to systemic hypertension. Again, I told you guys that there's nitroprusside or nitroglycerin we usually give to, put, I don't know if you've read through in first aid and pathoma that nitroprusside or even nitroglycerin, they reduce the preload. And why are they reducing the preload? So as to decrease the pressure on the heart. They not only decrease the preload, but nitroprusside also decreases the afterload as well. And because of that, the graph will be shorter than the original graph. So this was the original graph, and the dashed line was the patient on nitroprusside infusion, and you can see that it got shortened because the afterload and the preload decreased. All right, and if you kind of go through this, they're talking about the same thing, that it's going to cause vasodilation, and if it's going to cause vasodilation, as a result, both the preload and the afterload will decrease, and the balanced vasodilation will allow for the maintenance of stroke volume and cardiac output at a lower left ventricle pressure. So basically what they did was that they lowered the cardiac work. Like I mentioned, that they're going to decrease the load on the heart because the heart is already in a lot of pressure. It's pumping a lot. So what we do is we decrease the load on the heart, and for that we give sodium nitroprusside. It will collectively cause vasodilation, and it will decrease the preload and the afterload. So it will be, shortened than the original graph. Okay. All right. Next question. Again, waveform oriented question. So cardiac auscultation in the second right intercostal space reveals an ejection click along with a soft systolic murmur radiating to the neck. What sort of murmur is this?
Aortic stenosis.
Aortic stenosis. Okay. A normal volume and pressure tracing on the left ventricle is shown in the image below. Which of the following letters corresponds to the opening of the valve most likely affected in this patient? What's going to happen?
So basically, they are asking about the point where the aortic valve is open.
Okay. So what
basically-
point?
B, aortic opening.
B.
B. Yeah, I think it's B too.
Let me just zoom it a little bit for those who weren't unable. This is A, B, C, D. They were asking about aortic stenosis, and they wanted to ask about it when I think it was gonna open, right? So which of the following letters corresponds to the opening of the valve? Yeah. So when does the aortic valve open in this? B?
Yes, it opens B.
B.
Okay.
And
What's
it
gonna
closes
happen?
at C.
Okay. What's going to happen at A?
Mitral closing.
Mitral closing. Good. Okay. What's going to happen at C?
Aortic closing.
Aortic close.
What's going to happen at D?
Mitral opening.
What's going to happen at E? Not relevant. All right. Okay, so this is B, and yeah. So if you kind of see this over here, I told you guys that this graph is really important. Any sort of physiology graph is really, really high yield in terms of cardiology, physiology. So over here, mitral valve closes, aortic valve opens, aortic valve closes, mitral valve opens. And if you kind of see that they're talking about that during this phase, there's atrial systole that's happening. And during this phase, as you have volumetric contraction, relaxation, and then there's this passive ventricular filling. This is another graph on, present in first aid. It's kind of, I think, the waveforms, that ACV graph, and that's really important too. So kind of go through that graph as well. It's kind of merged into this graph. So go through that one as well. Okay. Next question. All right. So a phonocardiogram obtained at the location reveals the findings below. The patient's murmur is most likely due to which of the following mechanisms? Okay. So there's this 14-year-old girl who was brought to the office to establish medical care. Cardiac examination is significant for a murmur that is best heard at the left upper sternal border. What murmur is this?
Tricuspid.
Tricuspid?
Pulmonary.
Pulmonary.
Pulmonary. Yes. So you see that there's this mnemonic APTM, right? So aortic is towards the right, and then the P is towards the left upper sternal border, and then towards the left lower sternal border, you will see tricuspid. And mitral will be the between fourth and fifth intercostal spaces towards the lateral side. All right, so this is what they're referring to. It could be a pulmonary murmur. Okay, the patient's murmur is most likely due to which of the following mechanisms? So you see a pulmonic murmur, and what else? You see atrial septal defect at that area too, right? Yes or no? Is it yes or no?
How do you see pulmonic
Both.
murmur?
Yes, yes. Atrial septal defect and murmur pulmonic, both.
Yes. So you see atrial septal defect at the left upper sternal border. You see a ventricular septal defect where you see a tricuspid murmur, right? So it's ASD and VSD. So if they're referring to it, could be either pulmonic in origin or it can be, atrial septal defect. Okay. Patient's murmur is most likely due to which of the following mechanisms?
Ma'am, what is that atrial septal defect and ventricular septal defect that you said just now?
What is the ASD and VSD? What? What do you mean by that?
No, ma'am. What did you mean by ASD and VSD also come under this?
Oh, okay. Now, I was talking about the location. At this location, you also find an atrial septal defect along with the pulmonic murmur. And okay, yeah. All right. So what's happening? Come on.
It is a fixed split.
C.
Yeah.
Yeah. See, so this is atrial septal defect, like I said. So, locations are very, very important in terms of, remembering. You should be familiar by what murmur it can happen just by the location of it, because sometimes we're not able to, go through this phonocardiogram, or even sometimes we're not able to hear the murmur. Sometimes they do give audios as well, and they ask us to diagnose based on the sound we heard on the murmur. And trust me, I've never been able to intercept what type of murmur is this just by hearing it. So I had to go through the the differentials and the description that they gave regarding that murmur on that question stem. So left upper sternal border, it can be either a pulmonic murmur or it can be atrial septal defect murmur. Why? Because they both occur at this place, okay, at the left upper sternal border. And what's happening is that in atrial septal defect murmur, we see a widely split S2 that is fixed. Now, what do we mean by that is that there is no variation between inspiration and expiration, all right? And they are very, very consistent with atrial septal defect, a common congenital heart lesion. You should also know that the smaller, where do you hear a very large or a very harsh murmur? If the defect is small or big?
Small.
Small defect.
Very good. So the smaller the defect is, the harsher, the more audible the murmur will be. Okay. And again, when there's ASD, it will cause left to right shunting, and left to right shunting, this blood will have low velocity and turbulence, and that is why it does not create a murmur directly. Now, what's happening is that the increased volume of blood delivered to the right heart, that is the normal venous return plus the extra blood through the shunt, it causes an increased blood flow. Like, why? Because so the heart is normally working like it's used to. Now, because of the shunting, what's happening is that there's extra blood that's going on into the particular area of the heart, and that is why what's happening is that it's creating a sort of murmur that's early peaking mid-systolic ejection murmur, or a pulmonic flow murmur as well. I tell you that it can be a pulmonic flow murmur as well. Now, increased blood flow through the tricuspid valve can also cause a diastolic murmur, but that's not, really important at your level. What I want you to remember is just this educational objective, that the atrial septal defect leads to increased right-sided blood flow. And as a result, because of the left to right shunting that's happening, And the characteristic findings will be an early peaking mid-systolic ejection murmur over the left upper sternal border, that is a pulmonic flow murmur, and a wide and fixed splitting of the S2. So they will never give you a pulmonic murmur just like that in a question. They will always give you the pulmonic flow murmur in conjecture with the atrial septal defect. Okay, they will never throw it in a question like that. Okay, now diagnose a pulmonic murmur. They will always give you in relation with the atrial septal defect. So you should be very familiar with what's happening in both of these conditions. Okay. All right. Next question. The mother describes occasional episodes of severe dyspnea and cyanosis, during which the child quickly assumes a squatting position. What is this?
Tetralogy of Fallot.
Tetralogy of Fallot.
Tetralogy of Fallot. Which of the following mechanisms occur when the child squats?
So basically, the
Increase
peripheral
in
Increase the
vascular
systemic
resistance,
vascular resistance.
venous return
Venous
increases,
return.
and the pressure increases in the right side. Sorry.
Okay.
Mhm.
So what do you think is
And
the
it
answer?
causes reverse flow, which
Okay.
improves the stenosis.
option A is the answer.
Option E.
E.
Increase in
Increases the
systemic
systemic
vascular resistance.
Yes. So we know that the squatting will increase systemic vascular resistance, which will cause a decrease in the right to left shunt, right? So it will decrease the right to left shunt because of an increase in SVR, and it will improve cyanosis. What is this associated with? With what syndrome is it associated with? Tetralogy of Fallot.
Down
The
syndrome.
Down syndrome. Trisomy 21.
Yes. Yes.
Okay.
Down syndrome.
And with 22q11 syndromes as well, it's also associated with that as well. And we know that it is caused by the anterior-superior displacement of the infundibular septum. What is the most deadly, thing that is happening in the tetralogy of Fallot? Out of the four things that are occurring in the tetralogy of Fallot, what is the most
Pulmonary
deadly?
stenosis.
pulmonary
Pulmonary
stenosis,
stenosis. Very
severity
good.
of
So this
pulmonary
is
stenosis.
very, very lethal. You have to correct it. The other things are, they are also deadly, but pulmonary stenosis severity is the indicator of the prognosis of the tetralogy of Fallot as well. Okay. So I want you to remember. See, so what happens then if the SVR is increasing, then it causes a decrease in the shunt, and when the child assumes this squatting position, it is called our TET spell as well. See, it decreases right to left shunting, and thereby it increases pulmonary blood flow, and a child is able to breathe better in these conditions. All right. Okay, next question. Physical examination reveals bounding femoral pulses and carotid pulsations that are accompanied by head bobbing. Where do you see head bobbing pulses?
Aortic regurgitation.
Aortic regurgitation.
Aortic regurgitation.
Okay, aortic regurgitation. Very good. What are the causes of aortic regurgitation? Someone?
Rheumatic.
Bicuspid.
Endocarditis. Bicuspid aortic valve.
Very good. So the mnemonic bear, bicuspid aortic valve, endocarditis, aortic root dilatation, rheumatic fever, all are causing aortic regurgitation. We also see this widened pulse pressure, and these pulses are known as pistol short pulses as well. All right. So these are hyperdynamic pulses. These are also called as head bobbing pulses when they become chronic, when the aortic regurgitation becomes chronic. Again, aortic regurgitation can progress to left-sided heart failure. Very high yield for you to remember. Okay, so what is the answer in this book? I gave you the answer. What is the answer?
A.
A.
Okay, again. So bounding femoral pulses, we talked about that. Head bobbing pulses, I told you that. Again, all right. Okay, what else I want you to remember? That yes, left-sided heart failure causes left-sided heart failure if it becomes progressive. Okay. All right. Now let us talk about other murmurs as well, because they're also really important. What happens in aortic stenosis?
Systolic ejection murmur.
It's a systolic ejection murmur. It's crescendo, decrescendo. All right.
And is
It
it right
radiates.
upper
Pulse
stomach
radiates to carotids.
near the
Pulses
second
parvus
intercostal
retardus.
space?
Okay, very good. So it is also a marker that you can differentiate pulses on the basis of pulses parvus tardus. You can differentiate, aortic stenosis with hypertrophic cardiomyopathy, because sometimes a murmur presents the same, and the only way that you can differentiate between aortic stenosis and hypertrophic cardiomyopathy is based on pulses parvus tardus. So there will be weak pulses in aortic stenosis, and the pulses will be okayish and normal in the hypertrophic cardiomyopathy, but the murmur is going to sound same. So the only thing you can be, able to differentiate if it's aortic stenosis or HOCM, pick the answer that you will do it on the basis of pulses. Okay. All right. So where do we see aortic stenosis in patients who are a little old? All right, because it's age-related calcification that's occurring in younger patients. Most commonly, you will see them if there is any
Tricuspid aortic valve.
Bicuspid.
aortic valve. Very good. Again, it can lead to syncope, angina, dyspnea. We know that left ventricular pressure will be greater than the aortic pressure during the systole as well. All right. Okay. What do you mean by mitral regurgitation? Okay, you will get a hollow systolic, high-pitched flowing murmur. The mitral regurg murmur will be loudest at the apex, and it will radiate towards the axilla. Mitral regurgitation will usually occur post-MI, all right? So post-MI, it is the most high-yield cause that's happening, after post-MI, mitral regurg is going to happen, or after mitral valve prolapse, rheumatic fever. Tricuspid regurgitation will also have the same type of sound of the murmur. It will also be a hollow systolic glowing murmur, but again, it can be due to a right ventricular dilatation as well in tricuspid regurg. Both of the murmurs, MR or tricuspid regurg, they can also occur after infective endocarditis as well. Okay, all right. What about mitral stenosis?
Opening snap will be there.
Opening snap.
Diastolic murmur.
Very good.
Mid diastolic murmur.
Mid
Very good.
diastolic, yeah.
So I want you to, whenever you see a murmur, just see if it is systolic and diastolic. If it is diastolic, it can be two things: aortic regurg or mitral stenosis. If it is not one of those two things, then it is a systolic murmur. Okay. So try to differentiate on the basis like this. Try to compartmentalize each and every information into your head so that you can create a flow chart in your head leading to the answer. All right. In mitral stenosis, again, it can be a rheumatic fever complication. We know that the chronic mitral stenosis, it can result in left atrial dilatation. It can cause atrial fibrillation as well. We talked about Ortner syndrome yesterday as well, right? And it can cause heart failure as well. All right. So left atrial pressure will be greater than the left ventricular pressure during diastole in mitral stenosis. That's going to happen over there. All right. What will happen in patent ductus arteriosus?
Machine-like
murmur.
Missionary murmur.
Machine-like murmur, yeah.
Very good. Where do you see that? In what condition?
Rubella, congenital rubella.
Congenital rubella. Very good. Or sometimes in prematurity as well, you see that. Okay. All right. Where do you see ventricular septal defect?
Down syndrome.
Down syndrome.
Very good. Diabetic mothers.
Jesus Christ.
Diabetic mothers, very high yield cause, and Down syndrome, yes. So Down syndrome usually has ventricular septal defects. All right. Most of the times they will also have concomitant aortic defects or atrial defects as well, along with VSTs. But isolated VSTs are mostly linked to diabetic mothers. All right. Okay. And so we talked about that. Okay, now last thing, mitral valve prolapse. All right, what's happening in mitral valve prolapse?
Mid-diastolic click will be there. Mid-systolic click will be there.
Very good. So you will have it's a late crescendo murmur. It will have a mid-systolic click. All right. It will be best heard over the apex because it's a mitral valve prolapse. Again, it can be predisposed to infective endocarditis. It can be caused by a rheumatic fever, or it can be due to because of the myxomatosis degeneration.
Marfan syndrome.
Marfan syndrome can have mitral valve prolapse. Very good. All right. So we talked about every murmur. All right. We talked about every murmur, very high yield, and I wanted you guys to have a thorough revision of the murmur. Okay. All right. Next question. The blood pressure is 175. Physical examination shows an S4. Okay. All right. CT scan of the head and reveals no significant abnormalities. Which of the following age-related changes explains the blood pressure readings? So what's happening is that this 78-year-old man, he's evaluated for headaches that are relieved by over-the-counter acetaminophen. And the patient's blood pressure is 180, all right, very high. Again, his blood pressure is very high. And he also has an S4. What do you mean by S4?
Increased pressure.
It's a late diastolic murmur because of the atrial kick that is happening at the end as more blood is flowing into them.
At the time of rapid filling in a hypertrophied heart, it produces S4.
Very good. So S4 is an abnormal heart sound. It's not a normal heart sound, right? So if it is there, then that means it's something that's problematic. Now, S4 occurs in late diastole. It's also known as an atrial kick. Why is it happening? Because of the turbulence that's caused by blood entering the stiffened left ventricle, right? Because see, it's age-related changes. Maybe, left ventricle has stiffened over time, and it can always be heard at the apex. Again, you can see that in sometimes hypertrophy cases as well. It is, very, very common in older adults. Okay. What do you think the answer is?
Decreased diameter?
Increased
Decreased diameter.
Decreased diameter
of the
so the
aortic.
compliance is decreased.
No, there is increased arterial collagen deposition. With the age, the artery will get stiff. So it will be the increased arterial collagen deposition.
See?
Yeah.
Yes.
Very good. Again, physiological age-related changes, we discussed this yesterday as well. There's aortic stiffening happening, and the pulse pressure is going to increase, elastic replacement with collagen. There's mild concentric left ventricular hypertrophy. This is the same exact algorithm that we discussed yesterday as well. And how do we know that it's kind of physiological in nature? Because it is isolated systolic hypertension. If you see that the diastolic pressure is normal, right? There is no significant increase in the diastolic pressure. Only the systolic pressure is going to increase. So if there is isolated systolic pressure, then means they're most likely talking about a person who is just aging. All right. And again, what's happened is the replacement of elastin with collagen occurs. It usually occurs in elderly people. And again, because of the elastin getting deposited with collagen, there's reduced compliance of the aorta and the other large arteries, and that is why you're hearing this type of murmur. There's also left ventricle that stiffens over time, and you hear this atrial kick. All right, next question. She has no fever or shortness of breath and has resumed her daily activities. The patient has no other medical problems. Blood pressure is okay. Auscultatory findings recorded at the left sternal border are test. Which of the following is cause of the murmur depicted above? Okay, so we have a 35-year-old woman, and she is diagnosed with infective endocarditis. Okay, all right. What's happening? What is this?
Tricuspid regurgitation because the murmur is increasing on inspiration.
Okay, very good. And anybody else?
Like it would be the tricuspid regurgitation because it is occurring at the left sternal border, like you said, that APTM. So
Yes.
It's a hollow systolic murmur. So again, tricuspid regurgitation.
And right-sided murmurs increase during inspiration.
All right. Yeah. So again, the the where it's occurring, it is really really high here. Left sternal border. Now left sternal border. We know that they can be either pulmonary or tricuspid. We know pulmonary has got nothing to do with infective or endocarditis, right? We know that tricuspid regurgitation can happen after infective endocarditis. So you immediately went and put this as an answer. That's it. So sometimes even if you don't know this script, it's okay. But just try to use logic and common sense. Okay. All right. This is the same thing that we talked about, ventricular septal defect. See, it is found between at the left, third, and fourth intercostal spaces where you will hear probably tricuspid murmurs as well. Murmur is usually loud and it is accompanied by a thrill as well. And over here, if you kind of see, so the location can be very different. Over here, you can see that this is second and third. Over here, it's third and fourth. But in a small child, sometimes the location is not that evident, so it can occur at the same place as well. All right. So don't go on this that it's second and third written over it, third and fourth. Usually they're going to happen at the same place. All right. Okay. Next question. A 44-year-old man is hospitalized with multiple injuries following a motor vehicle collision. An AV fistula created by an injury would most likely result in which of the following changes? Very easy. Come on, guys. What will the AV fistula do? It will increase everything automatically. So what's going to happen? Is it A, B, C, or D? What will be the answer?
What is the question? B.
B.
D?
Question, please.
B. From the clue you said it's going to increase everything, so that should be B. Increase preload and increase. So I'll go for B.
What will happen in AV fistula? Okay, what does happen in AV fistula?
The total peripheral resistance will decrease, so like the preload and everything else should increase.
Of course. So what's going to happen? A, B, C, or D? C?
B.
No, I'll go for B.
B is B as in boy.
B, yes.
Very good. All right. Yeah. So again, if you kind of go through over here, that AV fistulas, it can be, sometimes AV fistulas they ask in terms of hemodialysis as well. They asked about cardiac physiology. They said that, there was this chronic kidney disease patient, and there's this fistula that we placed. What are the hemodynamic changes in terms of cardiology? And then they ask, arrows over there. So they love to ask AV fistulas in terms of hemodialysis. It can be, in terms of traumatic injury as well. So what's going to happen is that there's going to be an increased preload. And if the preload is going to increase, and that is why there's a decrease in the afterload. Now, why is there a decrease in the afterload? Can anybody tell me that?
Because there's less resistance because of the fistula, all the blood is going from arteries to the veins, so less resistance and less afterload.
There are no capillaries in capillary. The pressure will increase to go through the capillary. Yeah.
I wanted to hear the capillary version. So the blood is intermixing freely. They're not having to pass through the capillary meshwork, because if they pass through the capillary meshwork, what happens is that the resistance, it increases, right? So over here there will be a decrease in resistance, and that is why there will be a reduced afterload over here. And if there is reduced afterload and there is increased preload, as a result, what's going to happen that will be going to be an increase in stroke volume, which increases cardiac output and helps maintain blood pressure. Okay, and as a result, if you kind of go down and see that this leads to reduced SVR, that is reduced afterload, increased venous return, increased preload, and increased stroke volume. So this will be the graph on the section B. All right. Okay, guys, we're doing great. Next question. Several parameters are measured annually. Patients age 80 and are most likely to show which of the following changes compared to when they were age 50. All right. So what's happening is that there's this longitudinal study that's occurring. And they took patients from 50 to 80 who had cardiovascular disease. Several parameters are measured annually. Okay. So patients age 80 will have what as compared to when they were age 50? What's going to happen as you age? What happens to your systolic blood pressure, to your diastolic, to your pulse pressure?
Systolic increases, diastolic decreases.
We talked about this. Very good. So the pulse pressure is going to
Option
what?
D.
The pulse pressure would also increase, so it would be D.
All
D,
right.
D, D, D.
So you see, we talked about this in the previous question as well, that as we age, what's happening is that there's isolated hypertension that's happening, right? Because of the stiffening of the walls of the left ventricle, also because of there's collagen deposition. And that is why the systolic blood pressure is going to increase. Diastolic, we saw in that patient that it was normal. And when if it is normal and if it is very high, of course, the difference between those two values will be higher, right? And that is why the pulse pressure is high. So yeah, okay. Next question. So what's happening is a Doppler probe placed at the cardiac apex reveals the following blood flow patterns across the patient's mitral valve. Point marked by the arrow would best correspond to which of the following auscultation findings. All right, so there is this 52-year-old man who comes to the office with a 2-week history of SOB and dry cough. The patient has noticed decreased exercise tolerance that limits his daily activities. All right. So over here, what's happening?
Hello.
What's happening?
I didn't get the question.
Can we go through the question and see if we can
Yeah.
get any clue?
What's happening? So a Doppler probe
Filling,
was
ventricular filling, something like that.
when they're placing it towards the at the cardiac apex, and the blood flow towards the probe is, they want
Increasing.
So what's happening right here? What does it correspond on the auscultation findings? So these are shortness of breath, SOB, which means it can be mitral in origin, right? And it said that it's patient's mitral valve. So what are they talking about? Is it mitral stenosis or mitral regurgitation they're referring to? So see, if it is 2 weeks, then it cannot be. It cannot be. It cannot be stenotic. How can it? Can it be stenotic just in 2 weeks?
Regurgitation.
So what happens in mitral regurgitation?
Yeah, well,
I just told you guys what happens in mitral regurgitation.
fourth letter.
Come on, guys.
S3.
Heart sound.
Third heart.
Third heart sound. Because
Third heart sound increased volume.
Rapid filling phase.
it should be D, third heart sound.
So beta sound. D.
Third heart sound. Is third heart sound normal or flawed?
Flawed.
Flawed. Okay, very good. So we know that the third heart sound, it is seen in conditions like mitral regurgitation, aortic regurgitation, heart failure, thyrotoxicosis as well. And why does the S3 heart sound occur?
Fluid overload.
Very good.
For dynamic
Fluid
circulation.
overload.
So over here, they were referring to this condition called there's this severe mitral regurgitation. So whoever said mitral stenosis, try to go through the question and see if it is try to grasp out in nature. I said that the patient had shortness of breath. Shortness of breath, whenever the patient is having in terms of cardiology, most of the times mitral valve is compromised. Why? Because if the mitral valve is compromised, and there's backing of the blood, and where was the blood coming from? The lungs, right? And so it's going to kind of go into the lungs, and it's going to cause a problem, and that is why the patient will be having dyspnea. So try to make a loop, like I said. And then they said it was only for 2 weeks. Mitral stenosis takes a lot of time, years and years to develop. It cannot occur in 2 weeks, so it can be mitral regurg. So even if we don't know what's happening in this, if we just see this 4-liner description, we can be able to figure out, oh, they're talking about mitral regurgitation. Mitral regurgitation, third heart sound occurs. All right. Clear? Is it clear, guys?
Yeah.
Okay.
Yes.
All right. Next question. So what happens? Chest X-ray. See, I told you, where is it backing? In the lungs, and that is why the patient was having dyspnea. Over here, they again said that the chest X-ray showed cephalization of the blood vessel, curly B line, and a right pleural effusion. There was backing of the fluid into the lungs, and thoracocentesis is performed by the pleural fluid analysis in comparison to the plasma fluid. Which of the following pleural findings is most likely to be observed? Okay. What's going to
Low
happen?
lactate dehydrogenase.
Low LDH.
Okay. Yeah. So see, exudative and transudative, again, this is the Light's criteria that they had given into this. A pleural protein upon serum protein, if it is greater than 0.5, then they are referring to exudative. And if it is transudative, then this criteria is not met. Again, where do you see exudative pleural effusions in? In what conditions?
Pneumonia.
Pneumonia, very good. So infection, pneumonia, malignancy, rheumatological disease trend. Transudative, you see in heart failure. Most of the times you see it in heart failure, cirrhosis, nephrotic syndrome. And in order to differentiate that, we use this Light's criteria to kind of differentiate. This pathophysiology is very important. In exudative, the inflammatory increase in membrane permeability, whereas in transudative, what's happening? Either there's this hydrostatic pressure change or any oncotic pressure change. But over here, the membrane permeability will change. All right. So this is very, very high yield for you to remember. I want you to memorize this line. All right. Very high yield. Okay. Next question. All right. Bilateral crackles are present and S3 is audible. ECG reveals SD segment elevation and leads V2 through V6. Which of the following hemodynamic changes are most likely present in this patient? All right, so what happened? That there's this 55-year-old man. He comes to the emergency department after he collapsed 20 minutes ago. The patient reported chest pain. And then there's this diabetes and hypertension that's happening. Blood pressure is 80/50. Okay. He's in distress. There is STEMI that's going on. Again, very easy. What's gonna happen? What type of shock is this?
Cardiogenic shock.
Cardiogenic. What's gonna happen to PCWP?
Increases.
Increase
Option is D.
PCWP.
D.
Very good. Okay, so I told you guys that PCWP is also going to increase in one other thing. What's that?
Cardiac tamponade.
Cardiac tamponade. A type of an obstructive shock. So you can see this is very high yield for you to memorize. See, PCWP is always going to increase, all right, but it can only be increased in cardiac tamponade obstructive shock. Over here, if you can kind of go through, you see that in tamponade, the left side with measure PCWP is paradoxically increased. All right. So over here in obstructive shock, they said its PCWP is going to decrease, but you have to also go through these stars also. They mentioned a star, and if you go through this, they said that in the tamponade, the PCWP is going to be increased, right? So this is very high yield that you have to not only memorize this, but you also have to go and see these small lines as well. They're very important also. All right. And CVP, we talked about the PCWP, it is the left-sided. CVP is like I told you guys yesterday as well, that it's kind of like JVP. I know that they're two different things, but try to, for purposes of remembrance, try to see that, okay, they're both like kind of equal in the head. All right, so it's kind of like JVP. All right, okay. Last question for today, and then Dr. Moss is going to take over.
Excuse me, I have a question, Dr.
Yeah,
Mahim. So
yeah,
you
sure.
said CVP is like JVC?
Yeah,
Okay.
JVP.
Okay.
They
Thank
do a
you.
completely different thing. All right, they are jugular venous pressure is different and CVP is totally different. But for purposes of understanding, I want you to remember that CVP and JVP will function the same way in in these hemodynamic measurements and shock. They will function the same way. All right, but they're two different things. Okay.
Yes,
All right.
yes. Thank you.
All right. Last question for today is all right. So echocardiography confirms the diagnosis compared to newborn with a normal cardiovascular system. This patient most likely has which of the following changes in cardiac parameters. So what's happening is that there's a continuous murmur that's going on. All right. At the left sternal border and a bounding femoral and palmar pulses. All right. What do you mean by this? What murmur does she have?
PDA.
PDA.
Okay. So what's going to happen to the changes? Left atrial filling
Ventricle output will be increased and left atrial filling will be increased because of more blood from the lungs also, and SVR decrease.
Okay. So what is going to be the answer?
B.
No, C.
Option C.
C. Left ventricular output will be increased,
C.
SVR will be decreased, and left atrial filling will be increased. So we'll go by C.
Yeah, C. All right. Yeah. So what happens? We know that they were talking about patent ductus arteriosus. We know that in patent ductus arteriosus, there's left to right shunting that is going on. And as a result, there's this continuous murmur that's also happening. If you kind of go through down and see that what's happening is that in the PDA, what it does, it allows the blood from the aorta to flow directly into the pulmonary artery, and that will effectively decrease your SVR. And over here, you will see that there's a decrease in the SVR, right? Pulmonary overcirculation occurs with increased blood return to the left atrium and the left ventricle, and the left ventricle will compensate by increasing stroke volume. So what's happening is that whatever changes are going to happen in the left side will automatically be reflected upon the right side. All right. So try to, create a flow chart in your head like this, that whatever is going to happen on the left side is going to ultimately cause, right-sided changes. And you must have also, read about that the most common cause of right-sided heart failure is the left-sided heart failure, right? That's the most common cause of right-sided heart failure, is the left side of the heart, that it has failed and it caused a backup of all of the physiology that was happening, and as a result, the right-sided eventually failed. So most common cause of right-sided heart failure is the left side of the heart malfunctioning. So over here, this is the exact same thing that's happening. Whatever dysfunction the left-sided happened, it reflected upon the right-sided eventually. So the left atrial filling will be increased, the left ventricular output will be increased, SVR is going to decrease. All right. So I think
what is the mechanism for bounding femoral and palmar pulses?
Bounding femoral pulses?
Yeah, what is the mechanism behind it?
Yeah, so why are the bounding femoral pulses occurring in terms of patent ductus arteriosus? Are you asking this?
Yeah, ma'am.
Okay. Yeah, so over here you will see a bounding femoral and palmar pulses. Can anybody tell why it's happening? Anybody just try to think? Because there is increased blood flow and pressure in the aorta. What do we say? Increased stroke volume and cardiac output. So there is increased stroke volume and cardiac output. Why? Because of the pulmonary overcirculation that is occurring. And because of this, so what's happening is that there is increased blood flow and pressure in the aorta. And because of that, there are these bounding pulses are happening. All right. So whenever there is
That
any
means the same mechanism like aortic regurgitation.
exactly similar mechanism.
Thank you.
All right. Okay. So this was the last question for today. Okay, I think we have 1 to 2 more minutes, so we will do this one more question. All right. Empiric broad spectrum antibiotics and IV fluids are administered. The patient remains persistently hypotensive, and IV phenylephrine infusion is begun. Okay, what do you mean by phenylephrine? What is phenylephrine?
Pure alpha-1 agonist.
Alpha-1 agonist.
Very
That's
good. The infusion most likely induced which of the following intercellular changes in this patient? So we have a patient who comes to us because of 2-day history of left flank pain, dysuria, fever, and chills. Temperature is 102, blood pressure is 80/40, pulse is 140. There's CVA tenderness, there's leukocytosis, kyphioria, and bacteria. So the patient is probably septic. Because there's hypotension going on, fever, pulse is erratic. Most probably the patient is in sepsis, and that is why I don't know if you remember, but I told you guys that in exactly. So in septic shock, what we do in not only in septic shock but in sepsis, the treatment for sepsis is or even in septic shock is to give IV fluids along with antibiotics. Antibiotics are never the right answer on USMLE, all right? Just you have to give IV fluids along with antibiotics in sepsis. Why? Because the patients are extremely hypotensive and you need to correct that blood pressure changes as well, right? So always pick the answer that says IV fluids and antibiotics. Never one of them, okay? And so what are the intercellular changes that are going to happen?
In pure alpha agonist, there is a reflex bradycardia. That's why inward calcium, SV node will be decreased because of the low heart rate. And no direct effect on the heart. That means cyclic AMP will be no change or maybe decrease. And inositol triphosphate level vascular will be also increase, and decrease. Where will we answer that?
Okay. So the answer will be what? Answer is what?
A, I think, yes.
Yeah, so you're right. Again, we did not talk about phenylephrine is a selective alpha-1 adrenergic receptor agonist. We know that it causes vasoconstriction, and how it does vasoconstriction is an increased blood pressure by increasing inositol triphosphate levels in vascular smooth muscle cells. And because there's then increase in blood pressure, it triggers a baroreceptor reflex. What I want you to remember in terms of remembrance is that these are very high yields, in terms of receptor stimulated and change in second messenger. You need to be familiar with how inositol triphosphate, regulates the primary effects, how CAMP, is decreased in alpha-2, how CAMP is increased in beta-1, CAMP, IP3, very, very high yield. What are they doing? These all are very, very high yield for you to remember. Go through this educational objective. All right, the cyclic AMP activity in the heart mediated by beta-1 adrenergic and muscarinic 2 receptors, which decreases heart rate and myocardial contractility. The reduction in heart rate will be driven by decreased inward calcium current in the SA node. So it was basic, type of question. All right. Okay. I just want you to answer 3 questions. Where do you see white splitting? In what conditions do you see white splitting?
ASD.
Yes, ASD.
Intraseptal defect.
Fixed
Oh.
white split in
White
S2.
split.
Fixed wild ASD.
Okay. So fixed splitting you see in ASD, all right. White splitting, you sometimes see that in pulmonic stenosis or right bundle branch blocks as well. Physiological splitting is normal. Where do you see paradoxical splitting?
Left bundle
Aortic
branch block.
stenosis. Left bundle branch block. Very good. So with that, we are done for today, guys. Let me see. Is Dr. Moaz here? All right. Okay. Is Dr. Moaz here? Is he here? This was tough to understand. What was tough to understand, Dr. Subira? I'm just seeing the.
No, you explained it very well. There was a graph.
Oh, okay. Oh, okay. It's okay. So yeah, yes, these sessions will be. Oh, Talan Jum is also here. Interesting. Everyday session will be uploaded on YouTube. Yes. They try to record every session. Dr. Hamza tries to record every session and it gets uploaded on YouTube. If you guys have any questions, I can answer them. I still have got a minute and Dr. Moss will be joining us and then his class will continue. Any questions in terms of USMLE preparation, or if you're not able to understand, tell me. If you want me to change anything, tell me, give me feedback so that I can, incorporate that into your studying.
Okay. Ma'am, can you just suggest what are we supposed to do in our dedicated period?
Yeah. So dedicated period is just, that means that your exam is about to be in either 2 weeks to 4 weeks, right? And in the dedicated period, what I urge every student is to take maximum number of assessments, maximum number of NBMEs, maximum number of UWorld self-assessments. Try to revise each and every concept thoroughly. Focus on the biostatistics and ethics as well in the dedicated period. Try to go through pharmacology, microbiology. Those are the things that are, really, really, a person keeps on forgetting them again and again. Go through biochemistry. Try to go through the NBME high yield pictures. They're also very important. And yeah, those are the 4 to 5 things that you need to focus on in your dedicated period. Nothing aside of that. And then, yeah, of course, prayer and then chill. One day before my exam, I was watching Netflix. Trust me. I don't study one day before my exam. Who studies one day before your exam? You have given your entire 2 to 3 months for USMLE. Then what's going to happen one day before your exam? Nothing is going to happen, right? So take a chill pill, watch Netflix, do nothing, and then go and give your exam. That's it. Last minute changes, always you're not gonna remember them, right? Your entire concept will be destroyed if you try to learn anything last moment. And it's going to cause a conflict in the answers in your exam as well. So, that is why I say passive learning is really important. And what I mean by passive learning is, see, the amount of times I went through with you guys, okay, tell me this stenosis, tell me this murmur, although it was not related to the question, but I try to discuss every other option as well, because the more you guys are going to, hear my voice, the more it's going to get stuck in your head that, oh, Dr. Maheen said this, it can't be this, right? So passive learning is really important, and it gets ingrained into your subconsciousness. And once it gets ingrained into your subconsciousness, you know that instinctively some answers will not feel right to you. You will go like, oh no, I just feel it's not right. I don't know if it is right or wrong, but I'm feeling that this is not right. And that sometimes happens, and you're right, your gut feeling becomes right. And it happens only when you try to become, when you try to listen to things over and over again, try to, talk about those things over and over again. It gets ingrained into your consciousness. So it's really important. Otherwise, you're going to forget first aid and pathoma. See, how many times have you guys memorized it? And after that, even if I ask you the very next day, what did you learn from this page? And you will be like, oh, I've forgotten it, Dr. Mind. So that's the thing about books. You cannot retain books. All right. So try to participate in group discussions. Try to participate in discussions overall. Even if you're saying the wrong thing, try to say it, because then you know that it's not the thing. All right. So we're all here to learn. We're all here to grow. This is a safe space. Nobody is going to pull each other down. Even if it's the wrong answer to say it, according to me, this is what I feel. All right. Okay.
There's one last question. What's your take on FSMB taking over USMLE step 1? Because there's lots of controversies going on that people should take after FSMB taking over step 1.
Yeah. So right now, FSMB is not so. FSMB, takes step 3, right? Federal State Medical Board, it takes step 3. So what they wanted to do was that they wanted to create a platform where they can, have step 1, step 2, and step 3 all integrated together, and that is why they wanted to take step 1. But I gave step 3, and while giving step 3 it was regulated by the FSME. NBME collectively prepares the exam, so it really does not matter what regulatory body is going to take over, because the National Board of Medical Examiners, NBME, prepares your exam. So NBME prepared the step 3 exam under FSMB, and NBME prepared the step 1 and step 2 exam. It really does not matter, because the test maker is NBME. The regulatory body is different, that really does not matter. So don't worry about it. NBME is this pattern of making an exam, and they take an exam onto that pattern.
Okay, thank you, ma'am.
All right. Is Dr. Moaz here? I think I have to call him.
I'm here.
You're here? Okay.
Yeah.
Hi, Dr. Moaz. All right. Okay,
Hello.
guys, I'll see you guys tomorrow. Happy learning. Have a good day. See you guys tomorrow. Bye-bye.
Okay. So somebody asked here, what are the TET spells, right? So please explain a little bit. Can all of you see my screen? Can you hear me?
Yes, sir.
Okay. Okay. So first of all, let's start from TET spells. But okay. So what are TET spells? Somebody asked this question, and I thought that this might be related to the cardiology, the physiology. So that is why this thing becomes important, right? So we have to go over good diagram of the heart first, right? This was our diagram of heart. And now, so basically there is a disease which is known as the tetralogy of Fallot, right? So what is happening in the tetralogy of Fallot is that this is the pulmonary valve, right? Can everyone see the pulmonary valve?
Yes, doctor.
Okay.
Yes, Dr.
So this is
Mars.
the pulmonary valve. So in tetralogy of Fallot, this valve gets stenosed and this area gets stenosed, just like the aortic stenosis, right? So just like aortic stenosis, there is pulmonary stenosis in the case of what you call as the the tetralogy of Fallot. And at the same time, there is a ventricular septal defect here as well, right? So remember on the first day of the cardiovascular physiology, I told you a very important principle. And that principle was that during that heart takes the blood in the body takes the path of the least resistance, right? Now, what happens is that normally, just wait a second. Let me do one thing first. Right. So let's first do our squatting, right? So what is squatting? So we have heard first that during squatting, the tetralogy of Fallot improves, right? So if a person squat or if a baby is having problem and he starts squatting, the tetralogy of Fallot will improve. So how does this thing improves, right? So if a person squats, so this will be our topic today, and that is what will happen to the body when a person starts squatting. So as soon as the person starts squatting, the muscles in the body contract. So squat contracts a lot of muscles in the body. So as soon as the muscles contract, the this is this is step this is step the systemic vascular resistance increases, right? Right. So now the systemic vascular resistance increases. So I have told you that there are two pathways for the blood to go. One pathway in the tetralogy of Fallot is this pathway. It can go here, and the other pathway is this one. So the heart will go in that pathway wherever there is less amount of resistance. And normally the lesser amount of resistance is present here, here, right? In the aorta, right? So the aorta will give less amount of resistance in the tetralogy of Fallot, and the pulmonary artery will give greater amount of resistance. As a result, all of the blood goes to the aorta instead of going to the pulmonary artery, and blood does not get oxygenated, and it causes a lot of problems. So this is the pathophysiology of tetralogy of Fallot. Now, if as soon as the patient squats, this resistance increases a lot. This afterload increases a lot. And now the heart thinks that the least amount of resistance will be offered by the pulmonary artery. So all of the blood will go through the pulmonary artery, and then it will go through the lungs, and it will get oxygenated, and all of that problem is going to solve, right? But what happens in the case of TET spells, right? So TET spells occur whenever you are defecating, whenever you are feeding, whenever you are crying, or whenever you're doing any physical stress. So whenever you are doing all of those things, the pressure in the lungs increase, right? As soon as the pressure in the lungs increase, the resistance here would increase a lot. The resistance in the pulmonary artery increases. So I want to ask you a question. What kind of blood is present in the right ventricle? Is it oxygenated blood or the deoxygenated blood?
Deoxygenated.
Yes. So the blood in the right ventricle is the deoxygenated blood. So all of the blood here won't be oxygenated. Why? Because the heart will think it's better to move here through the ventricular septal defect and go directly into the body. As a result, more amount of deoxygenated blood will start going into the body, because heart will think it's better to send the blood here than to send the blood in the area where there is increased resistance. That is why all of the problem will occur in the case of TET spells. Right. So this is the main cause of TET spells. Right. Now the same thing is going to happen in another condition, which is known as the pulmonary hypertension. Right. So now you see that the more you understand the physiology of the cardiovascular system, the easier the things will get for you. In case of pulmonary hypertension, or let's skip the pulmonary, so there would be a lot more things. So let's first do the murmurs. Right. So let's move to the murmurs first. So today we are starting first from the splitting of S2, right? The splitting of S2. Now, the splitting of S2 is not as high yield, but the concepts that we will cover in the splitting of S2 are very high yield, right? So what are those concepts? So can anyone tell me what produces the S2 heart sound?
Aortic and pulmonary valve closure.
Yes, right. So aortic and pulmonary heart. So when the aortic and pulmonary valve closes, there would be an S2 heart sound. So as soon as the aortic valve closes and the pulmonary valve closes, so first let's write here. S2 is caused by closure of aortic and pulmonary valve. Now the problem here is that normally the aortic and pulmonary valves should close at the same time. So the S2 should be heard at the same time. But what happens is that as soon as we inspire, right? As soon as we start inspiration, we take a deep breath. So the mechanism of inspiration says that the thoracic pressure. So when we take inspiration, the pressure in the thoracic cavity decreases, right? So the thoracic cavity pressure would decrease. And what if I tell you that these are the lungs and if the thoracic cavity pressure is decreasing, will more amount of blood come now to the heart from the lower body or less amount of blood?
More.
More, exactly. Since there is a vacuum here too, in order to fill the vacuum, more amount of blood will come to the right side of the heart. So more amount of blood is coming to the right side of the heart. And when more amount of blood is coming to the right side of the right side of the heart will have more preload. When the right side of the heart will have more preload, it will need more time to empty the blood as compared to the left side of the heart. So what will happen is that since the right side of the heart is taking more time to pump the blood, and if you look at this diagram again, if we go here again, as soon as the blood is pumped out, all of the blood is pumped, then the aortic valve and pulmonary valve closes. So what if I say you that right ventricle is taking more time as compared to the left ventricle? Will the pulmonary valve close first, or will the pulmonary valve closed at later time?
Later time?
Yes, so the pulmonary valve would close at a later time. So the S2 now would be so so the S2, we will hear two sounds in the S2. One will be a sound of the pulmonary valve and the other will be of aortic valve. And the sound of the pulmonary valve will be heard later and that of the aortic valve will be heard first. And this is a normal physiological phenomenon, right? So this is a normal physiological phenomenon that during inspiration, thoracic pressure decreases. As soon as the thoracic pressure decreases, greater amount of blood will come into the right side of the heart, due to which right side of the heart will take more time to empty, and as a result there would be delayed closure of the aortic pulmonary valve. This is known as the normal thing, right? Now what if I say to you that in addition to this thing there is another thing? So for example, in addition to the inspiration that is causing delayed closure of the pulmonary valve, there is some other condition that is also causing delayed closure of the pulmonary valve. So in that condition, the normal splitting would become a wide splitting, right? Now, for example, if this was the aortic, so if this is the S2 heart zone, and you first hear this waveform, this would be the A2 waveform, and this is the pulmonary sound, so this is the P2 waveform. Now, in case of wide splitting, so for example, there is pulmonary stenosis, right? There is pulmonary stenosis that occurs in the tetralogy of Fallot, right? So pulmonary stenosis occur in the case of tetralogy of Fallot. Similarly, if there is a right bundle branch block, what does the right bundle branch block means? Let's go over this thing here again, right? So I told you that from the AV node, signals go into the right side of the heart and the signal goes into the left side of the heart. What if I say to you that this right side is blocked? This right side is offering increased resistance. Now, will the right ventricle contract earlier or will the right ventricle contract later?
Later.
Later.
Yes, so it will contract later. So again, the closure of the pulmonary valve would even be more delayed now, right? So this is known as the wide splitting. It occurs in right bundle branch block. It occurs in pulmonary stenosis. It occurs in both of these conditions, right? Now, there is a third thing, which is fixed splitting. You do not want to go into the pathophysiology of this thing. Just know that this occurs in the atrial septal defect. And this is very, very, very important that what is the condition where a fixed splitting of the heart occurs. So whenever there is atrial septal defect, fixed splitting of the heart will occur. Always keep this in mind. So fixed splitting of the heart is going to occur in atrial septal defect, right? Now let's move on to the last one, which is known as the paradoxical splitting. Now, what if I say to you, so the normal splitting was due to the fact that aortic valve is going to close, pulmonary valve is going to close later than the aortic valve. But what if I say to you that maybe there is some condition in which the pulmonary valve, aortic valve is going to close later than the pulmonary valve? Then we would hear a paradoxical splitting, in which we will hear first the closure of the pulmonary valve and then we would hear the closure of the aortic valve. And this is exactly the same as the wide splitting. So if there is aortic stenosis, or if the patient is having left bundle branch block, then this paradoxical splitting would occur, right? And this would be more pronounced in the expiratory phase. So the splitting of the heart sounds are done. Is anyone having any questions till now? Yeah.
Yes. How bundle branch block delay the splitting? Can you explain this one more time?
Okay. So look here. So let's hypothetically assume that it takes 1 second to the signals to go to this place, right? So from the AV node, it takes 1 second to go to the left bundle branch, and then the left ventricles contract, right? And it takes 1 second here as well. So what if I said you that this right bundle branch is now blocked, right? So there is a problem in it, and it is causing late signals to the right ventricle. So now the right ventricle would contract in 2 seconds. It will take 1 more second for the right ventricle to contract as compared to the normal condition, right? So now the right ventricle is taking 2 seconds to contract instead of 1 second. So that is why now the right ventricle takes more time to contract. So since it starts contracting later, the valve will close at a later time as well. So the splitting would be more pronounced in this case, right? And the same thing can happen with the left bundle branch as well.
Okay.
Right?
Thank you.
Sir, should we
Welcome.
remember the entire pathology of this, or we can just remember the main key things that are happening in that?
No, I think for this the pathology is important, right? So you want to know how does the intrathoracic. So first of all, the most important thing is the intrathoracic pressures. You want to remember that what happens to the intrathoracic pressure when you are inspirating, what happens to the intrathoracic pressure when you are expirating. Because if you play a closer look at this thing, the TET spells are related to thoracic pressures as well, right? So if I am crying or if I am eating, there is increased pressure in my lungs, because in order to cry you have to produce the sound from your lungs. So whenever you are expirating, the thoracic pressures in the lung cavity increases. In the thoracic cavity the pressure increase. So now the pulmonary veins are again facing increased resistance, right? So whenever you are facing increased resistance, the TET spells are gonna occur. So these are important. For you can skip the atrial septal defect one, that's not important, right? Because in case of atrial septal defect, just remember that it causes fixed wide splitting of the heart, right? So the atrial septal defect leads to the fixed wide splitting of the heart. Now we are going to move to the auscultation. So the murmurs, right? And this is the classic high yield NBME stuff, the murmurs, because whatever happens, right? You will get questions from murmurs. It's impossible that you do not get 2 to 3 questions from this topic, right? So do this as beautifully and as heavily as you can, right? Have a good grip on them, because every topic, every system that you want to incorporate, there would be the mention of a heart sound, right? Some S1, S2 splitting, S3, S4, or some kind of a murmur will be there. Right? So murmurs are heart sounds that are not regular, right? Now, before starting murmurs, so let's just do the murmurs first, right? So there are some systolic murmurs and there are some diastolic murmurs, right? So let's go here. Right. So remember, they are not gonna give you A, P, T, M, and then M there, right? They're gonna give you aortic A. So they are gonna say right upper sternal border in the second intercostal space. So this area is known as the right upper sternal border in the second intercostal space. This area is known as the left upper sternal border in the second intercostal space. This is known as the left lower sternal border. This area is known as the mitral area. So keep all of these area in your minds when you are doing the murmurs, right? Because in the future they are gonna give you this stuff, right? So the right upper sternal border, the left upper sternal border, the right lower sternal border, right? And then two areas. One is the carotids. and the other is the axilla. Keep these in mind. Now, if we start from the murmurs, let us look at first the systolic murmurs. So what is happening in the systole, right? So first of all, let's see what is happening in the systole so we can know what murmurs are present in the systole. So in the systole, this ventricle is contracting. So the blood has to go through this valve, right? So there could be a problem of aorta, right? And aorta might be stenosed, and when the aorta is stenosed, the blood might get very difficultly through it, right? So that is the first murmur, which is the aortic stenosis, right? But just but just wait a second. Right. So let's do this. So right. So this is very simple. So this is the mnemonic for the systolic murmurs. So the systolic murmurs, they are very easy to remember by this mnemonic. So Mr. Pass is the MVP, right? So MR stands for mitral regurgitation. And then P stands for the physiological murmur, right? So P stands for physiological murmurs, right? Flow murmurs. We are gonna go into the detail about what are the flow murmurs, right? And then A stands for aortic stenosis, S stands for systole, right? And then S stands for still murmur. This is another murmur which is present in the babies. And then M stands for mitral valve. So M stands here for the mitral valve prolapse, and V stands for ventricular septal defect, right? So these are the murmurs that are present in the case of aortic stenosis, right? So systolic murmurs, right? So mitral regurgitation, right? And then physiological murmurs, then aortic stenosis, then still murmurs, and then mitral valve prolapse, and then the ventricular septal defect, right? So these are the murmurs that are present here, right? Now, one other things. So now these are the systolic murmurs. That is the first thing that you want to remember. The other thing are what are the diastolic murmurs. So there are only two diastolic murmurs which are left behind. So that is AR and MS. So the mnemonic is very simple. It is arms. Right? So aortic regurgitation and mitral stenosis. These are the murmurs that are present in the diastolic phase. Now, let's move to the radiation of these murmurs. So two murmurs radiate normally. Aortic stenosis will radiate to the carotids. And mitral regurgitation radiates to the So a mitral regurgitation will radiate to the axilla. Right. So first of all, we did the systolic murmurs, then we did the diastolic murmur, and then we went to the uh, detail about where do these murmurs radiate, right?
Dr.
Any
Mas, could
question?
you please repeat the systolic murmur? Mr. Pass, what?
Yes. So it's Mr. Pass is the MVP, right? So MR stands for mitral regurgitation, right? And then another thing is that where does this murmur radiates? It radiates to the axilla. P stands for the physiological murmur. 8 stands for the aortic stenosis. H reminds you that these are the systolic murmurs. M stands for the mitral valve prolapse, and V here stands for the ventricular septal defect, right? So the VSD.
Excuse me, I always missing first S. What is the first S?
Which one? This one?
Still
First one.
murmurs.
First
Uh,
one. S and S, first one.
So this is the still murmur, and This one stands for the systole. Right? Don't worry, we'll go into the detail about each of these, and I have 2 to 3 other mnemonics as well. We can look over those as well, right? But first, let's go into the detail of each of these murmurs first, right? So the number one murmur is the aortic stenosis. We did this murmur yesterday as well, but we are gonna go into the detail. The first thing that you want to know about, so the things that you want to know about the murmurs are, the number one thing is that what is the character of the murmur. So this is a crescendo decrescendo murmur, right? Which means, so they can give you this picture as well, which means if this is the S1 and this is the S2, this murmur will increase and then this murmur will decrease. This is known as the crescendo decrescendo murmur. And where do you hear this murmur? You hear this murmur at the right upper sternal border. So right upper sternal border. Where does this murmur radiates? This murmur radiates to the carotids. Now the demographic is very important. In which age these murmur is normally present? This murmur is normally present in the age of more than 60 years. But if this murmur is present in an age of less than 60 years, then it means that the patient is having bicuspid aortic valve, right? Now, what are the signs and symptoms of this murmur? So people who are having this murmur would have syncope, angina, and dyspnea. And we have gone into the detail about why these things occur in this murmur, right? Now, some other related things regarding these murmurs are, in this murmur, the S2 is very soft. So the F2 is very soft, right? And the pulses are very weak. So there would be weak pulses with delayed peak, which is known as a buzzword, pulses parvus et tardus, right? So it is pulses parvus et tardus. Now, just give me 1 second. Because I think these murmurs are important, let me pull up some UL question on these murmurs. Right, so just look at this question. And what do you guys think this and the answer to this question would be? Anyone?
Aortic stenosis is 50s.
Yes, right. So this is the
Yes.
concept that they want to test you, right? So this is the concept. They want to see that do you know that what does bicuspid aortic valve lead to? So it leads to the aortic stenosis in the 50s. And sometimes I have seen questions mention another option and they say aortic stenosis in the 60s as well, right? So this is the way they want to test you regarding aortic stenosis. And the other way they want to know is what is the pathophysiology? Why does aortic stenosis occur? So aortic stenosis occur due to valve calcification. So there is valve calcification and that leads to aortic stenosis. What would be the murmur? The murmur would be a crescendo decrescendo stall just border, right? And the finished, they would be delayed. And at the same time, the murmur would radiate to the carotid. And these people also have sometimes S4 heart sound. And why do these people have S4 heart sound? This is important. Because in case of aortic stenosis, the heart has become so narrow that there is increased afterload in these patients. So whenever these patients, whenever the heart is now gonna contract, it will need increased force to contract, and as a result, there is remodeling of the heart. Or whenever, and now since there is remodeling of the heart, it is gonna lead to ventricular hypertrophy, and whenever there is ventricular hypertrophy, there is S for hearts. Now there are two more murmurs, which are the MR and TR. So mitral regurgitation and tricuspid regurgitation, right? So mitral valve murmurs are always heard at the apex of the heart. Tricuspid murmurs are always heard at the left lower sternal border. Right. So it is heard at the left lower sternal border, and those are heard there. Regarding the character of this murmur, both of these murmur are the hollow systolic murmurs. Right? Now, if you remember, on the first day of cardiovascular anatomy, we covered a topic which was known as the rheumatic heart fever, right? So there was a patient whose age was 50 years old, or for example, if a patient comes to you and that patient age is 19 years old, and now that patient is had a sore throat and they did not get medications for that sore throat, and now they are presenting with the murmur. What do you think the most common murmur this patient would have? So this patient would have a murmur of mitral regurgitation, right? Now, at the same time, the murmur of mitral regurgitation goes to the axilla. Again, there is a murmur of tricuspid regurgitation as well. Where is the murmur of why? What causes the murmur of tricuspid regurgitation? Two things are gonna lead to the murmur of tricuspid regurgitation, and these two things are very high, right? You cannot forget these two things. The number one is the placement of a permanent heart pacemaker, right? So if you place a permanent pacemaker in someone, so for example, if a person had a second degree heart block or a third degree heart block, and that patient came to you for treatment, and now they are saying that this person is having a murmur which is holosystolic, and that murmur is present in the left lower sternal border, what do you think this murmur would be? Now, obviously, this murmur would be a murmur of tricuspid regurgitation, and the cause for this murmur would be a placement of pacemaker. Why? Because whenever you are placing a pacemaker, you have to go to the tricuspid area, so through the tricuspid valve. And when you go to the tricuspid valve, it will cause problems in the structure of the tricuspid valve, and that would lead to a lot of problems, right? So the murmur would be due to the tricuspid, due to the problem of tricuspid valve, and that would cause the problems. The other reason the tricuspid can cause a tricuspid regurgitation is infective endocarditis, right? So infective endocarditis. Why? Why does infective endocarditis usually why does tricuspid endocarditis causes tricuspid murmurs? Why? Because it's very easy to inject. So what is the major cause of infective endocarditis? Now they want to know this from you. So the most important reason for an infective endocarditis is the injection of drugs. And it's much easier to inject a drug in a vein than in an artery, right? So most of the drug users or drug abusers inject the blood in their veins. And you know that the blood from the veins goes directly into the atria, and after atria comes the tricuspid valve. So the first valve that comes is the tricuspid valve. So that is why most of patients with drug abuse have a murmur of tricuspid regurgitation, because effective endocarditis is going to affect the tricuspid valve in the first phase, right? Now we have another murmur. So now what are the other causes of mitral regurgitation? The most common cause of mitral regurgitation is due to ischemic heart disease or after MI. Why? This is because, for example, if this is the mitral valve, so now again, let's go to the mitral valve. So this was the mitral valve. Now, what if I say to you, so what happens in systolic heart failure is that heart cannot pump the blood. A lot of blood will get accumulated here. When a lot of blood gets accumulated here, the valve has the capacity, right? The valve has a capacity. So, for example, you are holding a thing for 1 hour or 2 hours or 3 hours. There would come a time then that at which you would say, "I'm sorry, I cannot hold this thing anymore." So when you cannot hold this thing anymore, the blood is gonna go back into the left atrium, right? So the blood is gonna go back into the left atrium, and the mitral valve is gonna fail. So there would be regurgitation, and this would be known as the post MI or post ischemic heart disease or secondary mitral regurgitation. That mitral regurgitation is occurring due to heart failure, right? Now another cause is rheumatic heart fever, right? So these are the numbers. So we are clear to, are we clear till here? Okay. Now we are moving on to the murmur of mitral valve
Sorry.
prolapse. Yep,
Doctor, I
yep,
have
you
one.
can ask you the question.
Yeah,
Yes,
the
in
mitral
case of
regurgitation murmurs, I didn't get it.
I cannot get you, I could not get your question. What are you saying? Mitral regurgitation?
Cause of mitral regurgitation murmurs, I didn't get it.
Okay. So there are three causes of mitral regurgitation murmur. One is mitral valve prolapse that we are just going to study. The other is ischemic heart disease, right? So if the patient is having ischemic heart disease or the patient is having heart failure, then that patient would have a murmur of mitral regurgitation. And the third cause is rheumatic fever, right? So went into the detail about rheumatic fever, but we are going to cover rheumatic fever again in the pathology section as well, right? So these are the causes of mitral regurgitation. Yes, there was another question as well.
yes, so in first aid, I can see that in case of rheumatic fever, there is also tricuspid regurgitation and also aortic regurgitation. So which one would be like more correct if they asked us like in case of rheumatic fever is option as both that aortic and tricuspid regurgitation is there, both are there. So which answer we gonna be take?
Okay, okay. So normally, whenever there is rheumatic fever, there are 2 to 3 murmurs that will be present because it causes pancarditis. So pancarditis means 2 to 3 murmurs are present at the same time. Now, what they are gonna do to confuse you is that um, they are gonna give you the description of 2 to 3 murmurs. So they are gonna give you the description of one murmur, and then they are gonna ask you about that murmur. So it's not possible that they will give you 2 murmurs at the same time, right? The one thing that is asked a lot regarding rheumatic fever, the one thing that they are going to confuse you is in early phase of rheumatic fever, the murmurs that you would get will be the murmurs of regurgitation, right? So in early rheumatic fever, the murmurs will be of regurgitation. So now it could be MR or it could be AR, it could be TR, right? So it could be mitral regurgitation, aortic regurgitation, tricuspid regurgitation. They are not going to ask you, they're not going to give you 3 options in the same question. But what they could give you is they could give you the timeline. So in the first 1 year or 2 years, you would have a murmur of regurgitation. But if the patient is coming after 10 to 15 years, the murmur would most likely be a murmur of aortic stenosis, and that would be a murmur of mitral stenosis. And this then the patient would be having a syndrome which is known as the Ortner syndrome, right? So we have discussed in detail about this Ortner syndrome. So that is how they are going to ask you these things, right?
Yeah,
Now,
thank you so much
welcome.
for clarification.
Yep, you're very welcome. So now we're moving on to the mitral valve prolapse, right? So what is mitral valve prolapse? So this is a benign condition, but the main cause this can cause, the main thing that it can lead is it can lead to an infective endocarditis, right? That is what you just want to remember about it, right? And this is a late crescendo. So this murmur is a systolic murmur, but there is a mid systolic click. That is all you want to remember about this murmur, right, guys? Because there are some things in the first aid or in the USMLE that are very high, and then there are some things which are not. So if you are gonna remember all of the causes of mitral valve prolapse, that won't be important, right? You can just remember one thing. In developed countries, the most common cause of mitral valve prolapse is myxomatous degeneration. So they are gonna give you this, and believe me, you would see some questions on this. So there would be myxomatous degeneration of mitral valve. One thing they are going to give you is this. Now, in developing countries, the most common cause of mitral valve prolapse is rheumatic fever, right? In developing countries, the most common cause of mitral valve prolapse is the rheumatic fever. So, for example, if they give you a patient of 30 years of age and they say that this person has come to you and this person has a murmur that is present at the apical area of the heart, and this murmur has a mid systolic click, the first thing that should come to your mind is mitral valve prolapse. And then they say, what is the most common cause of this murmur? Then you'll see in the question if this is this a developed country or is this a developing country? Because if this is a developed country, then the murmur would most likely be due to myxomatous degeneration of mitral valve, right? So it would be due to myxomatous degeneration of mitral valve. But if the murmur is due to if the murmur is in the person who is in the developing country, then it would be due to rheumatic fever, right? So keep these things in mind. Right. Now, there is another murmur which is known as the VSD. So the ventricular septal defect, which occurs in the tetralogy of Fallot. And right, this murmur will again be heard at the, because this murmur is a tricuspid murmur, it would be heard at the left lower sternal border, and it's a holosystolic murmur. Just okay, so that's it about this murmur. Now we are going to cover two more murmurs, which are the AR and the MS. So there are a lot of causes of aortic stenosis. Number one could be it again. It can be caused by bicuspid aortic valve. So this is the mnemonic here, which is the beer mnemonic. So it could be caused by bicuspid aortic valve. Could be caused by endocarditis. But again, if in the question they give you that the patient is taking injectable drugs and he is at risk of a murmur, what murmur is he at more risk of? So if there is a right-sided murmur and there is a left-sided murmur, always pick the right-sided murmur. Why? Because normally the infective endocarditis affects the right side of the heart. It does not affect the left side of the heart as much. And then it could be due to rheumatic fever as well. Now this murmur is a decrescendo diastolic murmur, right? And it is heard at the left upper sternal border. So decrescendo murmurs mean that it is a diastolic murmur and it will be like this, right? So this is the diastolic murmur and this murmur will be present like this. It's gonna decrease. Now there are some important things regarding this murmur, right? So I remember once I was in an so it was an intercity all medical colleges quiz and I was participating in that quiz. And the final question it came down was to the aortic regurgitation murmurs, right? And if we answered that answer question correctly, then we would have won the quiz. And these things were regarding this thing that I'm gonna tell you now. So first of all, there is white pulse pressure. And why is there white pulse pressure? I've already told you. Now, if a question of aortic regurgitation comes to you, or if a question of any murmur comes to you, and the blood pressure is something like this. So if the blood pressure is 160 by 50, then think of aortic regurgitation. The normal pulse pressure is 40 to 60. But if it's the pulse pressure, how do you calculate the pulse pressure? You subtract the systolic blood pressure from the diastolic blood pressure, right? And if the blood pressure is systolic blood pressure is very great, then it means that the patient is having aortic regurgitation. Now, when you check the nail beds of these patients, the nail bed would be pulsating, right? So the nail bed of these patients would be pulsating, right? And then there is some other things as well, which is known as the pistol short femoral pulse, right? Now, what is pistol short femoral pulse? The pistol short femoral pulse is also known as a Trobbe's sign, right? So it means that there will be loud snapping sound that would be heard over the femoral artery, right? So this is known as the pistol short femoral pulse, right? And then there would be head bobbing as well. So these are all the different ways they are gonna test the aortic regurgitation murmur to you, right? All of these things can come when they wanna test aortic regurgitation murmur to you, right? Now, I have already told you that it has vibrant pulse pressure. It has a pistol short pulse. They can say you the patient is having a water hammer pulse as well, right? So all of these things will be present in this patient. Now, the last murmur is the mitral stenosis, and I already told you. So, how is the murmur of mitral stenosis? This murmur has first an opening snap. So, if this is the S1, this is the S2, and so after S2, there would be a sound wait, after which an opening snap would be heard, and after that, there would be rumbling and a delayed murmur, right? Now, this interval between the S2 and opening snap is very important. Why? Because the lesser is the distance between this the opening snap and the S2, the greater is the murmur of mitral stenosis. Remember, this is very important. The murmur of aortic stenosis comes here. So now they are going to ask you, if a person is having mitral stenosis, which of the following things predicts the severity of the murmur? And then going to give you one option that would say that the intensity of the murmur itself. And another option there would be the distance, the interval between the opening step and S2. So, and the distance, the interval between opening step and the H2 would be that. Now, the most common cause of this murmur would be rheumatic fever, and it would occur late in the course of rheumatic fever after 10 to 15 years, right? Again, there would be Ortner syndrome in this patient, and this would lead to atrial fibrillation as well. Yeah. So, does everyone know about the Ortner syndrome yet, or they wanna know more about it?
You want to know more?
Well, no more.
Okay. So, what was the Ortner syndrome? Let's go over it again. So, this is the mitral valve. This is the mitral valve. What happens in rheumatic fever is that the mitral valve gets stenosed. There is calcification of the mitral valve. Now, what will happen is that blood is gonna stay here. Blood will stay in the left atrium. There would be a lot of blood now in the left atrium, and the left atrium would get enlarged. Behind the left atrium, we have a trachea, and we have a esophagus as well. And we have a nerve which is known as the left recurrent laryngeal nerve. So when the left atrium becomes very large, it presses behind those three things. The atrium, the esophagus, that leads to dysphagia, the trachea that leads to hemoptysis, and the left recurrent laryngeal nerve that leads to, then what do you say,
Hoarseness of voice.
that would lead to hoarseness of the voice, right? So this is the Ortner syndrome. Now, mitral stenosis also leads to a condition which is known as the atrial fibrillation. And how does mitral stenosis lead to atrial fibrillation? So, if you remember, the first day that we discussed, that we started cardiology, Dr. Hammer told this as well, and I talked about it as well, that our body is designed in such a way that no thing stagnates anywhere in the body. So, for example, if something happens and our body, something stagnates anywhere in the body, the thing that will happen is that eventually a lot of blood will stagnate there and there would be clotting that would occur, right? So, the similar thing happens in mitral stenosis, right? So, if a lot of blood stays there, that lot of blood is going to cause clotting and it would activate some foci of electrical activity near the pulmonary veins, and that thing would lead us to atrial fibrillation, right? Now we have a last murmur, which is the murmur of patent ductus arteriosus. And this is the most easiest murmur of all. Why? Because this is the murmur which would be present in systole as well as diastole, right? So the murmur of PDA is present in systole plus diastole as well. And this is a machine-like murmur. Now, why does this murmur becomes important? This murmur becomes important because if the patient is having a murmur of PDA, then it means that this patient will most likely be having rubella syndrome, right? And what is rubella syndrome? Rubella syndrome means that the patient's mother had rubella infection during pregnancy, and now the patient would have the triad of rubella syndrome, which includes PDA, that is patent ductus arteriosus, plus cataracts, plus sensory neural hearing loss. Right. Now we have to go over some. So till here, our murmurs are completed. Now we are going to go over the maneuvers of the murmur. Any question?
Before you go on, please could you explain mitral stenosis again?
Mitral stenosis?
Yes.
Okay. Okay, so the first thing regarding mitral stenosis is the area. What is the area at which you are going to hear the mitral stenosis? So that area would be the apex. Okay. Okay. Just give me 1 second. I will be back. Just give me 1 second. Okay, guys, I'm back. Sorry. So I was saying, so can you hear me? Yep. Yep. So I was saying that during mitral stenosis, so the mitral stenosis was the murmur that would be heard at the mitral area, right? So mitral stenosis would be heard at the mitral area, and then mitral stenosis first start with a bang, and that bang is known as the opening snap. And after opening snap, there is some rest, and then there is a late diastolic rumble, right? Now, there are two components of mitral stenosis. The first is the opening snap, the second is the diastolic rumble, right? So, both of these things are present here, right? Now, the other thing is that you want to know about the mitral stenosis is that what is the most common cause of mitral stenosis? The most common cause of mitral stenosis would be, the most common cause of mitral stenosis would be aromatic fever, right? The most common cause of that would be the sequelae of the rheumatic fever, right? So rheumatic fever would lead to that condition, right? Now, another thing is that mitral stenosis can lead to a condition which is known as the Ortner syndrome, right? So this was till here till now. So guys, I have to go for some due to some reasons. I have an emergency, so I have to go. So tomorrow we are gonna start the pathology, and along with the pathology, what we will do is we will do the maneuvers as well, right? Okay. So you guys have to wanna study this, and we will do the maneuvers, and we will start. Okay, so we will do the maneuvers and we are going to start the pathology as well. And we will do the pathology, but the pathology would become very easy as we have covered most of the pathology in the physiology section as well. I tried to cover all the pathophysiologies in the physiology sections, so the other thing will become easy. Yes, so
And
JVP as well, right?
yes, JVP as well. Thank you.
A- what are you saying?
You promised us that you will also cover JVP, jugular
Ye-
venous
Yes,
pulse.
so I would do JVP as well, right? So maybe after 30 minutes or so, I can ask Dr. Ahmed to create a session. So after 10 or 15 minutes, I can come again and then we can discover we can discuss the JVP. If you
Okay,
guys,
Dr. Moaz, do you want to give me the opportunity to explain JVP to them?
yep. So you can
Yes,
explain
but
the
I have some.
JVP and then I can join after 10 to 15 minutes and then we
Okay,
can do
sure,
the maneuvers, right?
sure. Okay,
Okay.
so just wait for me 1 or 2 minutes. I'm just joining my session from my iPad, and we are going to discuss JVP in a big detail. And believe me, everything is going to be so clear for you guys. Okay, and Dr. Moaz is then going to add on things. Is that clear? Just give me a second.
Yes,
Okay?
Doc. Thank you.
I'm just joining from my iPad. Okay, just give me 1 minute. So for JVP, I have an important, a really interested kind of story for you guys. If you remember that story, JVP is going to be like, very easy for you guys. Okay, so as I'm just joining the session, so are you guys enjoying the sessions with Dr. Moaz and Dr. Maheen?
Yes, doctor.
Okay, that's perfect.
Yes.
Okay, just give me a second. Okay, so let me just remind you that today I'm going to share the task, but in today's task, we are going to revise UWorld, right? So you have UWorld revision. Like we have almost finished the UWorld MCQs for physiology yesterday. Today we are going to have a revision session in Discord server. So kindly join the Discord server as well. Okay. And I'll be there taking the session with you guys.
Doctor, it's so difficult to go to Discord. Yesterday,
Sorry?
some of us tried, we could not. To join in Discord is very difficult for some people.
Okay.
So people try and try, they cannot. So I don't know what
So
we are doing
after
wrong.
okay. Okay. So after the session, I'll just give you an orientation session on Discord. Don't worry, okay? Just give me a second. Let me just connect my microphone. Okay, so let me first of all share my screen. Okay. Can you just please fix your mic, Dr. Margaret? Okay. Can everyone just see my screen?
Yes.
Hello? Okay,
Yes.
perfect. What is JVP? JVP is basically jugular venous pressure, right? But for that, you must know a concept, right? So, okay, this is 1 minute. Okay. So the topic which we are going to discuss is JVP. So what is JVP? JVP stands for jugular venous pressure, right? But before that, you should know a concept, right? For example, let's suppose this is your heart. Okay, I'm just drawing your heart. Okay, so this is going to be your superior vena cava, your right atrium, your left atrium, and your ventricles. Okay, just like that. Okay, so this is going to be your superior vena cava. And we know that, okay, and your inferior vena cava somewhere here. We know that all of the deoxygenated blood from your veins basically drains into your atrium, right? Hello?
Yes, doctor.
Yes, sir.
All of the blood from your veins basically, that drains into atrium. And as the veins do not have proper walls, right? So whatever pressure is present within the atrium would be same in that of most of the veins, right? Is that clear? Because they are in continuation with one another. We do not have any walls in between them. So that's why the pressure, whatever pressure is present in your atria, that same pressure is going to be present within your veins. Okay, in contrast to the chambers of heart, like we know in the right ventricle, you have more pressure as compared to the atrium. Why? Because they have walls. They do not have a proper connection. There are walls present. But the veins and the atria do not contain any walls, right? That's why the pressure, whatever pressure is present in the atria, same pressure is going to be present within the veins as well, right? Is that clear? So let me just write it down. Pressure within the atria, that is right atrium, is equal to pressure within your veins, right? So let me just draw your jugular vein, right? Let's suppose. So we know we have our jugular vein, and ultimately, okay, I'm just drawing a picture in order to make you clear things clear. Okay, ultimately this vein is going to drain into your atria, right? I'm just drawing a simple illustration, right? So consider this as a jugular vein, right? Hello?
Yeah.
Yes.
Okay. So
Yes.
we discuss whatever pressure is present within the atria, that same pressure is going to be present within the jugular vein as well, right? So for example, let's suppose if this is the amount of blood present within the jugular vein, right? So let's suppose if I just put a ball, a table tennis ball. The table tennis ball is like a light structure, light ball, right? It is having very less weight, right? Hello?
Yes.
Yes.
I'm just creating a scenario, right? So for example, if I just place a table tennis ball here, and with that I just draw a scale, right? Scale of 1, scale of 2, scale of 3, scale of 4, and scale of 5. 1, 2, 3, 4, 5. And this scale is going to tell me, like the pressure, let's suppose. So for example, whenever the pressure within the atria increase, right? That is whenever the blood is more. So this ball is also going to move upward, right?
Yeah.
Yes.
Like we have more blood, so the ball is going to move up, right? Because both of them are in continuation with one another. whatever change is experienced in atrium, same change is going to be experienced within the jugular vein as well, right? So and we can just I have already drawn the scale, so I can just tell you, like for example, let's suppose these are some arbitrary number, that for example, if we have 20 milliliter of more blood, the ball is going to move up, and at that time you are going to have 3 mm of Hg pressure. This is only for your concept. Is that clear?
Yeah.
Yes.
Okay, perfect, right? So let's discuss now the details of jugular venous pulse. Okay, so now let's suppose all of this activity which happens during contraction and relaxation. For example, if I want to draw a graph of that, right? So how would that graph look? The graph would first of all be having a wave which is known as A wave. Okay, what do we mean by A wave? We know that during diastole, what happens? Like in the end of diastole, your atria contracts, right? Yesterday we discussed that.
Yes.
Okay, and as the atria contract, what happens? The pressure within the atria would increase, right?
Yes.
Yes.
Okay.
Yes.
And as the pressure within the atria increases, so it would just push all of the blood into your ventricles. But as the pressure is increasing here, won't you think that this ball is going to move up?
Yes, it will.
Yes, the ball is going to move upward, right?
Yes.
Because
Yes.
whatever pressure is here, that same change of pressure would be experienced in your jugular veins as well. So during atrial contraction, what happens? The ball is going to move upward, but as the atria give all of the blood to the ventricle, the pressure is going to drop down. So what happens? Your ball is going to move down. For example, if with this ball I have attached, let's suppose a page, right? And with this ball I have attached a pen and a page, and on the pen I have some ink, an ink pen. So you can just keep in mind. So whenever the atria contract, with this ball I have a pen with a proper ink within that, and I have just attached a page. So what happens on the page? You are going to see a graph moving upward and then coming downward. Does that make sense?
Okay.
Yes.
Does that make sense? So atrial contraction, for example, okay, this graph is basically the graph which I am going to draw is the events. So can I say that as the atria contract, the JVP is going to raise and then it's going to come down. So let me just name it as A wave.
A wave.
Does that make sense?
Yeah.
Okay,
Yeah.
perfect.
Yes.
Okay, so let me just tell you, for example, if I have an atrial fibrillation, would I be having this this A wave?
No.
No. Perfect. So in atrial fibrillation, we won't be having this A wave. Let's just discuss the second concept, that is C wave, right? Okay. We know that whenever the blood comes to your left ventricle, at the end of, all of the blood is now present within the ventricle, right? Then systole would occur, right?
Yes.
Okay, and this mitral wall is going to be closed during systole, right? The mitral wall is going to be closed during systole.
Yes.
But as the systole occurs, the pressure here would increase, right?
Yes.
Yes.
Okay, as the pressure here is increasing within the entire vessel, won't it push this valve little bit up?
Yes.
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 Okay, if this valve is pushing up, so won't the pressure in the atria increase?
Yes.
Yes.
Okay, if the pressure in the atria increase, won't this ball go a little bit up more?
Yes, it will.
Yeah.
Okay, and after the systole, it's again going to come to its location. So again, if I've attached a pen with an ink and a paper, so won't I see another graph like that? But as this is a little bit, bulge, this is a little bulge of your wall. So it would be less as compared to that of atria. So the wave which would be formed would be less than that of atria. So let me just call it as C wave. So C for contraction. As the right ventricle contract, you are going to see C wave. Does that make sense?
Yes, doctor.
Yes.
Okay, perfect. Okay. So what happens as the systole occurs? What happens? Okay. After that, after your atrial contraction, what happens? Your atria is going to relax as well, right? Once this wall is closed, atria is going to relax then, right? Because it have to fill a lot of blood coming in, right? So for that, the atria have to relax, right?
Yes.
Okay, as the atria is relaxing, what happens to pressure? Pressure would drop down, right?
It will drop.
Yes, and this ball will just come down.
Yes.
And I have just attached a pen with a paper and just drawing this, this entire process. So won't I be seeing a big drop like that? Yes or
Yeah.
no?
Yeah.
Yes. Yes. Okay. So atrial relaxation, it's going to give you an X wave, right? Or X descent, right? And another thing which you can mention, whenever the atria is relaxing, okay, so at that time your ventricle is also going to, it's going to push the blood, and ventricle also going to relax, right? And whenever the ventricle is relaxing, the pressure is going down. So now this wall is going to move like that, okay? So again, it's going to drop the pressure, and as the pressure is dropped, the ball is going to move down. And if you just draw a graph of that, it would just give you an X descent. Does that make sense?
Yes.
Yes. Okay. Now your atria get relaxed. Whenever your atria get relaxed, so now it is going to accept a lot of blood, right?
Yes.
Okay. So
Yes.
whenever the atria accept a lot of blood, what would happen if I have a lot of blood? Again, pressure. What would happen to the pressure within the atria?
It would increase.
It would increase. And as the pressure increases, would the ball move upward?
Yes.
Yes.
If the ball is moving upward, so on if I have a pen attached to that, so won't it be like that graph?
Yes,
Hello?
yes.
So it's basically known as V wave, which is due to increased volume against closed tricuspid wall. Like it's relaxing, tricuspid is closed, but it would just accept blood from your veins. The pressure is going to increase as it is accepting. So the ball is going to move upward. And if I'm just drawing a graph of that, it will just give me a V wave, right?
Mm.
And again, after that, what happened? Your tricuspid wall is going to open. So as the tricuspid wall open, right? We know the three phases of diastole. First of all, opening of your tricuspid. Secondly, we discussed yesterday, the valve is only going to act as a pathway, right? And the third is your atrial kick, right? So let's discuss this phase. Whenever directly your valve get opens, all of the blood is going to enter into your ventricle. And as the blood enter into ventricle, again pressure would drop. Ball would move down. And as the ball move down, so on the graph, it's going to give me Y wave. That's all about your jugular venous pulse.
Mm. Okay.
You could go over it one more time, please.
Okay, no problem. No problem. No problem, right?
If you want, Dr. Ahmed, I can repeat it.
Okay, who is going to repeat this for us? Yes, Dr. Muaz.
Yes, so I can repeat it. Okay.
Sure, yes.
Okay. Okay, I won't be as good as Dr. Ahmed, but I'll try my best. Okay. So, what is jugular venous pulse? So, first of all, we have to look at what's jugular venous pulse, right? So, basically, your neck is just like a small window into your heart, right? So, nahi baba. Bhai, my net was साढ़े 7. Okay, so your neck is just like a window into your heart, right? So everything
Doctor,
that is
sorry to interrupt. Are you sharing your screen?
yeah, can you see it?
No.
Oh no, let me share it again.
We are able to see it.
Not
Okay, let
yet.
me. I'll share it again for you guys. Oh, okay. Okay, so I was telling you that your neck is like a small window into your heart, right? So, if your neck is like a small window into your heart, everything that is happening in your right atrium, you can see it through your neck. That is the beauty of your neck, right? So, in the neck, there is a vein which is known as the jugular vein, right? That vein carries the blood back into your heart, right? If your heart is working well, everything is fine, you can easily see that through the vein. But if there is any problem in your heart, especially in the right atrium, that JVP will tell that problem, right? So that is why JVP is very important, right? So now, as the heart contracts and as the heart relaxes, everything that is happening in the heart is going back into the vein, right? So just think that the heart is a replica, so the jugular vein is a replica of whatever is going into your heart, right? So that is the first thing that you want to know. Jugular vein is a replica of whatever that is going into your heart. So we use special scales to like know what is going into your heart. But right now we are focusing on the JVP right now. We don't want to see how the JVP works. So like how do we see those tracings? We could go into the detail about that later, but that thing is not going to come into your steps. So the thing that is going to come to your steps is the JVP, the venous pulse, right? So the first thing is that whenever you see the JVP, there is first of all an A wave, right? What is this A wave? So first of all, the pressure of the JVP rises. And why does the pressure rises in the A wave? Because so JVP just mimics your atria. So whenever the atria contracts, so if we go back into this picture, so that is why I was telling you that picture was so important. So if we go back into this picture, let's draw the JVP here as well, right? So if we see here, this was the point during which the atria was contracting, right? So as soon as the atria contracts, right, what will happen is that your JVP is going to go up, right? Because when the atria contracts, the pressure in the atria increases, and as the pressure in the atria increases, the pressure in the JVP is increases as well. Just think that JVP is exact replica of your right atrium, right? So the pressure in the atria is increasing, the atria is contracting, and when the atrium is contracting, the JVP pressure increases as well, right? Now, one important thing that comes here is that what can cause this A wave to even become larger, right? One can this A wave become very large, right? So just now that we have discussed, whenever there is tricuspid stenosis or whenever there is pulmonary stenosis or there is right bundle branch block, the heart, right side of the heart is going to have more blood, right? So when the right side of the heart is going to have more blood, the atria would need to press harder to get that blood out. Since now the atria is pressing harder, it will need more pressure, and that more pressure would be reflected in the JVP, and that thing is known as the cannon wave, right? So you would get a cannon A wave in JVP if there is some problem, especially the preload of the right side of the heart is increased, right? Now, after the A wave, there is a next wave, right? So this is the A wave, and after the A wave, what will happen is that the atria is going to relax for a second, and then immediately after that, the right ventricle is going to contract. Now we know whenever the ventricles contract, so now we are standing here. When the ventricles contract, the tricuspid valve and the mitral valve will close. And when all of a sudden the tricuspid and mitral valve will close, they will again cause a pressure in the atria because they will bulge back into the right atrium. And when they bulge back into the right atrium, a pressure will be created in the right atrium and we will have another wave, right? And that wave now is the C wave. So it is due to the contraction of the ventricles. So now we have discussed two waves. The number one wave is due to the atrial contraction. The second wave is due to ventricle contraction. Again, in the ventricular contraction, the tricuspid valve will go back, it will go into the atria, and that will cause the wave, right? So now they can ask you another question here, right? And this is a very technical question, but they can ask, and definitely can ask you this, like the C. So the C wave of the JVP, they can ask you the C wave of the JVP coincides with what heart sound, right? So if you look carefully, the C wave happens when the tricuspid valve and the mitral valve close. So the C wave will
Yes, sir.
coincide with the S1, right? So the S1 is happening just before the C wave. Now, after these waves, the heart is now going to relax. Why? Because now the atria is going to relax, right? Because I told you at this point, when the ventricles start contracting, the atria are starting to relax. And that relax is going to be seen in the JVP as well, right? So now the heart is going to relax and there is going to be an X descent. This is known as the X descent. Now, what are the conditions in which atria? So I just want to ask you this simple question. Don't need to focus hard on this one. What are the conditions in which atria will again have more blood? Even in the relaxation phase, what are the conditions that cause the relaxation phase to have blood in them?
Tricuspid.
Right heart failure.
Yes, exactly. So in tricuspid regurgitation, blood will go back into the atria, right? So there will be blood in atria again. So the atria is like, damn it, I cannot relax now. So when the atria cannot relax, we cannot get that X wave, right? Now again in the heart failure, the blood is gonna back into the atria, so you're not gonna get that wave again. So the X wave will be absent in tricuspid regurgitation or the right heart failure, right? So remember, these are the things that they want to integrate here, the pathophysiologist with the physio, so the pathology with the physiology, right? So what were the things that are going to cause cannon A wave? What, whenever there is more blood that is present in the left ventricle, and whenever there is blood that goes back, so whenever there is tricuspid regurgitation or right heart failure, the X descent is going to be absent. So we are clear till here. The A wave stands for the atrial contraction, the C wave stands for the ventricular contraction, and after both of these waves we are going to have a relaxation of the atria. So during the relaxation of the atria we are going to have an X wave, right? Now,
Yes.
now the whole heart has pumped all of the blood. Now we are back at this point, right? Now you see the aortic valve is closed and the mitral valve is closed as well. No valve is open. Now what will be happening is that more now the blood will start pouring back into the right atrium again, right? The right atrium is gonna fill up again, and as soon as the right atrium fills up again, you will get a V wave, right? So V wave stands for the filling of the right atrium, right? So when the right atrium fills again, we have the V wave, right? And remember, this is the point where the V wave will be occurring. Now I'm gonna relate it to the pressure volume loop. This is the V wave. And remember, if you guys remember carefully, I told you that during the filling of atria to the ventricles, what were the two phases of filling of the atria ventricles? Can anyone tell me that?
Passive feeling, and then there's some contraction at the end.
Yes. So there is contraction at the end. So we have, so the contraction at the end stands for the A wave. But we haven't seen the passive filling phase yet in the jugular venous pulse. So now all of a sudden now again the atria are gonna empty. And when the atria are gonna empty, this is gonna again become a flat line. This is known as the Y descent, right? So during the Y descent, so the Y descent is gonna again cause the right atria to empty into the right ventricle, right? So this is the thing, that these are the waves and that is how these waves work. Now if we look at the pressure volume loops and if we make it very simple, we can see that first of all, let's start from here. So at this point, atria contracts. So when the atria contracts, there is an A wave. After the contraction of atria, the next thing that you want to see is that the ventricles start contracting. When the ventricles start contracting, there is the C wave, right? When the ventricles have finished contracting, now the ventricles are going to relax. So now there would be an X descent, right? And after the X descent, right, what will happen again is that there would be filling of the ventricles, so there would be V wave, and finally again there would be passive emptying of the right atria, and that would be the Y wave. So the jugular venous pulse determines the right atrium, and it will go through these five phases, right? So if you just remember these five phases, then the jugular venous pulse becomes very easy for you. And remember, always correlate these waves with the S1, with the S2, and how these things work. So this was a diagram. I left this diagram on the purpose at that time, right? So I told you that when the atria contracts, mitral valve will close at the same time, right? So when the mitral valve is closing, you can see there is the S1 here, right? So this is the thing that they can ask. They can give you this diagram, but if you have good concepts, this thing become easy, right? So this is how these things work, right? So have a good look over this and try to understand this by yourself, because we have covered almost all of the cardiovascular physiology. So take a good look on these things, right? And now only the maneuvers of the heart are left, and I think we will do that maneuvers in the pathology section, right? So let's go over. So this was all the cardiovascular physiology, and from tomorrow we are going to start the cardiovascular pathology, right?
Sir, can you just point out the Y wave on the pressure volume loop?
Okay, wait. So this was the pressure volume loop, right? So now what was the Y wave, right? So the Y wave was when the right atria empty into the right ventricle, right? So here all the ventricle is filling right now. So this is the V wave, right? And the pressure is building up, the pressure is building up, the pressure is going up, right? And all of a sudden, the wave, it opens. So this would be the Y wave. Here, there is the Y wave. When the mitral valve opens, right? Right?
Yes.
Right. So this is the Y wave, this is the A wave, this is the C wave, right? And then, right? So this is, and then here is the X descent first, right? So this is some. So did all of you get the JVP? Any confusion in the JVP?
No, doctor.
Okay, okay, thank you so much.
Doctor,
I remember I was doing my UL self-assessment one, and I had skipped JVP for that because I did not think it was important. And then a question came from the JVP and I was just flabbergasted. I was like, what is this question? So then I went back and then I did all of the JVP again and all of those things again. Right. So so it's very good that you're having a good grip on all of these steps, because believe me, it's very worth it, right? So right now, it won't make a lot of sense to you that why are these things important. But in the end, believe me, guys, when you will be finishing your first aid, so a lot of people, so everyone finishes their first aid, right? So and remember, the first aid is the gold standard for you world. But it matters how do you do the first aid, right? So I did my first aid in a normal way first, but then I did a second pass of the first way in a good way. So I remembered, so I focused on every single thing in the first aid, and the result was that even today, that whenever I'm discussing any topic with any of my colleagues, and anyone, right, and even during my residency interviews, they ask me some clinical questions and some pathophysiological questions, and I was able to answer them in a very good way, right? And these understandings will go a long way with you, right? Especially in step 2 and in step 3. So Dr. Maheen told me that told you guys that there was a lot of passive learning, and that is so correct, right? When you will be sitting in your exam, believe me, at that point there would be almost 100 to 200 things that you will say that I have heard this thing somewhere, right? Dr. Moaz, maybe Dr. Moaz told this thing, or Dr. Maheen told this thing. So the passive learning is a very big part, right? You cannot just cram up this stuff. You read this stuff again and again and again and again, and somewhere these things stick in your mind, right? And when you are completing your first aid, when you are done with your first aid, for the first time, you will see the differences in your NBMEs, right? So all of you would have friends that are doing the USMLEs as well, and you would see that how much better of a prep you have against them, right? They would be not knowing a lot of things. They would be cramming and doing a lot of buzzwords, but things would be very much clear for you, right? And that is my method of teaching. I always like to teach people the pathophysiologies and the detailed stuff and the detailed way how things work, because remember, medicine is always about almost 80% of the step 1 is internal medicine, right? The surgery and OBGYN step is very less, right? And medicine always works on 3 principles: physiology, pharmacology, and pathology, right? And we are going to focus in on each of these, and we are going to dissect this as much as we can, right? So we are going to link every single thing, we are going to integrate every single thing, so these things become easier for you and you have these things on your fingertips, right? So guys, happy learning. We'll take it till here today, and then we'll start
I have a
from tomorrow.
question.
Yes, yes.
I'm sorry. Um, Looking at the diagram, where do you situate S2? Is it on the V wave? Because I'm looking at the diagram that you showed.
Wait.
Is it so? Is it because we had a question on that on UWorld?
Okay, so this is the S2, right? So this
Uh-huh.
is the S2. So remember, what was the X wave, right? So no. So the X wave was that wave when the atria was relaxing, right? When the atria was relaxing, right? And when there was rapid ventricular ejection, right? So whenever there is rapid ventricular ejection, so whenever the rapid ventricular ejection will finish, the aortic valve is gonna close, right? And somewhere between the rapid ventricular ejection, halfway between it, the aortic valve is gonna close, and at the same time the aortic valve will be present. So during the mid of the X wave, when the atria is relaxing, the ventricles are gonna stop contracting, right? And the aortic valve is gonna close, right? So this will be the point here, where the S2 will be present, right here. And now, if you guys remember, I told you what was the S3, right? So S3 was, so what was S3? So let's focus on the S4. S4 was that sound that was heard during the atrial kick, during the atrial contraction. And if you see here, it correlates so well with A wave. So when the atria contracts, whenever there is A wave, there would be S4, right? And what was when did we hear S3? I told you we heard S3 when a lot of blood gushed during the passive filling phase of the left ventricle, right? And the passive filling phase of the left ventricle is represented by this V wave and Y wave. So as soon as the Y wave comes, the S3 comes as well, right? And if you see, whenever the S3 is coming, there is a sudden increase in the ventricular volume as well here, right? So there is a sudden increase in the right ventricle, so the ventricular volume as well. And I cannot see the atrial volume here. If there was an atrial volume, you would have seen at this as well. But see, as soon as the ventricular volume increases, there would be that. But after that, the ventricular volume starts increasing very tiny in a very little amount, and then the atrial contraction kicks in, right? So that was the S1, S2, S3 here.
Yeah.
Okay.
Sir, could you repeat those mnemonics for the murmurs before you go?
Okay, I would send those mnemonics to Dr. Ahmed and he could send the mnemonics in the group, right? I have the better mnemonics and I would send those in the group, right? Even for the JVP. So I have done another thing. So I'm starting another thing from today. I'm going to share all the mnemonics for all the things that we are going to study. And I would, so whenever we start complete studying, whatever the difficult topics are, I would share the mnemonics of those things to you guys at the end of the lecture. So I'm going to give those to Dr. Ahmed and Dr. Ahmed would share with you. Okay.
Thank you.
Welcome. Okay, so guys, I have to go now. Good, have a good day. Have a good learning. So bye bye.
Thank you.
Welcome. You're all of you are welcome.
Thank you so much, Dr. Moaz, for having such an amazing session. So it was all for today, and see you after half an hour in our microbiology session. Okay. Thank you so much.
Thank you.
Thank you, Dr. Ahmed.